know how to.
Yeah, so I've gone ahead and now we have to be careful because there may be Zoom bombers, and we're trying to be as careful as possible. But I've gone ahead and opened up, so you should be able to share now.
Perfect. We can see it now.
Excellent. Let me quickly.
So we are the Zoom bombers. I like the term.
I hope they don't come in here.
Yep.
I'll throw them out.
All right, again, everybody, a very warm welcome. Thank you, Dr. Khan and Dr. Lee, for the very kind invitation and the kind remarks, Dr. Khan. At no point in time do I, consider myself as an expert at COVID-19 and cardiovascular complications. All of us have, in the last few months, learned the hard way by taking care of patients and learning from our colleagues across the globe about how COVID-19 affects not just the lungs, but also its involvement in a multi-organ scenario. So we started doing this daily webinars with physicians across North America, Europe, and in Asia, and we started learning from each other. I spoke about COVID-19, that was early April, and then we started to collect data that was being presented and that was being published across the globe in various journals, and we finally published that data that was in May 8th. I will present some of that data. I will share the citation, and everybody is welcome. It's a free download, and everybody is able to pursue that. I do not have any conflict of interest related to this presentation. The overview, we all only have 15 minutes, and Dr. Khan has asked me to be on time. I know there are a bunch of other excellent speakers that I also want to listen to. So I would put on my timer here so that I know exactly where I am. So I'll briefly, since this is the first talk, we are in the COVID-19 era, give you an introduction and background of epidemiology of COVID-19. Briefly discuss about acute cardiac injury, discuss briefly about arrhythmias, go through some of the published data on cardiac manifestations of COVID-19, and briefly for our healthcare providers that primarily practice in a primary care setting, the question that comes about is the use of ACE inhibitors and COVID-19. So quick background, the origin, what we know of at this point in time is that it originated in Wuhan city in Hubei province in China, this somewhere in December 2019, maybe end of November. On January 12th, it was the WHO named it as the 2019 novel coronavirus. On January 20th, this is what we know of the first known case that happened in the United States. And then, as everybody knows, it started to spread. It started from Seattle, then the hotbeds became Chicago and the tri-state area in New York and New Jersey. On January 30th, it was labeled as a public health emergency of international concern by WHO, and we started to talk more about by the abbreviation of COVID-19 rather than its original name. On March 11th, it was declared a pandemic, which means it is in numerous countries. More than 209 countries have been affected by this particular virus. This afternoon, I looked up the data and the total number of cases, over 6.6 million. This is across the world, over 391,000 deaths. If you look at, this is the data from our article till April of 18th, you can see that there is a significant logarithmic increase in the number of cases. But thankfully, the number of deaths do not match the logarithmic scale of cases. So that there is a significant increase in the number of deaths since the virus came on the scene, but we can see that a lot of people are able to recover. As Dr. Khan mentioned, the mortality is anywhere from 1 to 3%. Based on what study you look at, it could be as high as 4.3%, but it is still significantly, a lot of people actually still recover. This is global data. You can see that the number of new cases as of June 2nd are still rising. The number of daily deaths have started to come out after they reach their peak somewhere in April. If you look at the top 10 countries of the world, not a title that we wanted, but US is the number one as far as total cases is concerned, and new cases and total number of deaths. Not a surprise to anybody, in this day and age. United States, total number of coronavirus cases close to 2 million with 110 deaths. If you look at the five largest states are the usual suspects: New York, New Jersey. In Utah, we have around 11,000 cases with 316 new cases in the last 24 hours and 117 deaths. This is data till this is correct till this evening. If you look at the US, we reached our peak somewhere in April, and then there is a slow decline. It's not the decline that we wanted, but there is a slow decline in the number of daily cases, and the daily deaths, as you can see on the right-hand side of this slide, is also reached a peak somewhere in mid of April and has steadily come down, but we're still seeing a lot of deaths. Talking about cardiac comorbidities, there are two things that you have to consider. Number one is patients that have pre-existing cardiac comorbid conditions, they have worse morbidity and mortality. All the data that you look at, these are the patients, the elderly, patients that have diabetes, hypertension, comorbid cardiac and lung disease. These are those that will do worse. So obviously, for the healthcare providers in a primary care, in a primary care office, our job is to try to make sure that we tell those patients to be extra careful. The elderly, the patients that have cardiac comorbids, pulmonary comorbids, because every single study that has come out has shown increased worsening morbidity and mortality in those patients. If you look at all the inpatients, patients that are admitted either in the ICU or in the hospital, patients that have acute cardiac injury measured by any cardiac enzyme, troponin or CK-CKMB, have higher morbidity and mortality. They are more likely to be intubated. They are more likely to be on vent support. They are more likely to die. So obviously, patients that have acute cardiac injury measured by our standard test, there's likely that they will do worse. If you look at the mechanism of cardiac injury, there's more than one reason for cardiac injury. How the virus enters the heart is through an ACE2 enzyme, and I will discuss that briefly later on. ACE2 enzyme is also expressed in numerous other organs of the body, especially the kidneys and the lungs. It enters the heart and it can cause cardiac injury either by direct damage of the cardiomyocytes by viral invasion. It can also, there can be an increased inflammatory response and release of numerous cytokines, which could also cause a systemic inflammation, also affecting the heart, just like we see in acute sepsis, we see in any other significant systemic illness. And obviously, patients that have significant lung disease, like ARDS, can also have significant damage associated or correlated damage with the heart. So that can also cause cardiac injury. So when you look at acute cardiac injury, you should never forget, as Dr. Khan mentioned, the acute coronary syndrome. So there can be patients that will present with acute coronary syndromes that have concomitant COVID-19 positivity. But we still have to manage the acute coronary syndrome. This is because of plaque rupture. And yes, I have noticed the same thing. I have never seen that many late presenting MIs that I have in the last 3-4 months. Especially in the elderly population, population from the nursing homes. They have presented late, completed infarct, and that is something that is not just in cardiac, but we have seen patients with other abdominal conditions that presented late. I ended up seeing them because all of them ended up having atrial fibrillation. So we were consulted on them, but patient with bowel perforation because they were delayed presentation to the hospital. And then you can have positive cardiac enzymes just with severe systemic illness in a patient that has acute ARDS due to COVID-19 or pneumonia or bilateral lung injury. They can have positive cardiac enzymes. Not surprising to us, we see that all the time when we do our consultations in the ICU. The other thing we spoke about is direct viral injury to the heart and presenting as myocarditis. We saw a few case reports that were presented in February, and then we started seeing more and more of these patients that presented with myocarditis, especially from the data from China also showed that these patients received coronary angiograms and they had patent epicardial coronary arteries, and primarily it was myocarditis. Interestingly, myocarditis was also seen in the first coronavirus, the first SARS virus that came out. When I was practicing at that time in the Middle East, and I saw some of these patients, and they did present with myopericarditis at that point in time. One other thing is that there's a lot of thrombophilia that is associated with this COVID-19 systemic illness. Many patients present with acute pulmonary embolism and associated positive troponins. A bunch of, as an EP as well, I love to talk about rhythm abnormalities. So I want to briefly say that we have seen a lot of patients that have concomitant atrial fibrillation when they are having ARDS or without even just bilateral acute lung injury, they present with atrial fibrillation. We saw a 42-year-old lady who had no past medical history who presented with severe flutter to the point she was hemodynamically unstable, was cardioverted. She did not cardiovert. She ultimately died. But she had presented with atrial flutter and with a very fast heart rate. So we have seen both of these manifestations. Some of the end results are ventricular arrhythmias. We have seen patients that have ventricular fibrillation or ventricular tachycardia. Hydroxychloroquine is now a moot point. I was talking about more previously, but the recent article in New England Journal of Medicine have probably laid to rest that hydroxychloroquine, the data does not support significant use of hydroxychloroquine. So therefore, I'm not going to talk about the issues with Torsades and QTC interval, which earlier we were talking about in earlier talks. I'm going to be very brief. I think we're already time. You can go to this article. It's available for free download, and it's in a PDF version. But you can go through how from February 7th till, I think we looked till April or late March, all of the articles we have, their summaries over here. And then it shows what I've already mentioned. Most patients have cardiac comorbid conditions. They are more likely to get hospitalized. Once they're hospitalized, if they have acute cardiac injury by troponin, by cardiac enzymes, they are more likely to do worse. They're more likely to be intubated, ventilated. They are more likely to even die. So, and then there's a bunch of other things that we have looked at. You can look at all of this, at your leisure. I have covered most of the things. They will have increased BNPs. They can have myocarditis as well, and their prognosis is much worse if they have acute cardiac injury. I think I'm going to skip this. Briefly want to talk, this is a very common question that most of us will get in any presentation, any webinar, is that what do I do with ACE inhibitors? We talk about the ACE receptor as being how the COVID-19 gets intracellular. Do we need to stop ACE inhibitors? So in a stable patient, there is no data to suggest that we should stop ACE inhibitors. All the major societies across the Atlantic Ocean, the US and European societies do not recommend stopping ACE inhibitors. So we continue giving ACE inhibitors. However, if a patient is very sick, now hemodynamically unstable, just like in any other patient, we will stop their ACE inhibitors if they are very sick or they have acute kidney injury. Many of these patients also develop acute kidney injury. So just like in any other patient, you will stop or hold ACE inhibitors. That is the same reason why you will do it in these patients, not because of COVID-19, because of their hemodynamic compromise. With this, I will end. Obviously, this was not an exhaustive review. We could not do it in 15 minutes, but I'll be happy to answer any questions even later on chat or even afterwards. Again, I thank the moderators and the host for inviting me today. Thank you very much.
All right, thank you, Dr. Khalid. It was a great presentation, especially coming from someone who has expertise both in EP as well as interventional cardiology. Do you think, is there any data that, is there any increased number of certain cardiac deaths? Because again, with this anxiety and fear around COVID-19, do we have any data on that in nursing homes or in other elderly facilities?
If you ask me, I will say yes. I think there is increased, many of these deaths that are happening, they're just labeled as COVID-19 in New York and New Jersey. I would say I do not have epidemiological data, but just from my own personal anecdotal experience and from talking to colleagues across North America, I think there is increased risk of certain cardiac death because of these untreated MIs that are not presenting to our normal ER settings or inpatient settings. I would say yes.
Thank you. All right, guys, again, if you have any question, you can either raise your hands or write your question in the chat box. Let's move on to the next topic. I'm going to invite Dr. Elliot Brinton. He is the president of Utah Lipid Center. He is endocrinologist and world-renowned expert in lipid management. Dr. Brinton?
Thank you. Let's see if I can get this to work here. Whoops, that's the wrong one. Hold on just 1 second. Got to go back to, oh, come on. I was getting some pictures there. Let's see, where are we? Right here. Okay, there we go. We'll go to home. There we go. Okay, very good. Can everybody see that all right? And
Yes.
Can everybody hear me okay? Yes? Okay. So thank you, Sohail, for the opportunity. This is so great. You've put this together so nicely. We've got, 55 participants. It's an honor to be with you this evening. So, and you'll notice here that I've got my email address at the bottom. You're welcome to email me with any questions beyond what we may have time for, since the time is short. So, a little disclosure, I do have some potential conflicts, but I love, again, Sohail and Viet for putting this together without any commercial support. So that's very cool. All right, so we're going to talk a little bit about the new cholesterol guidelines. We're going to talk about statements about triglycerides and individual medications. Notice that we've got a new medication for LDL, bempedoic acid. We'll talk about that, and some new data on icosapent ethyl. So this is just a screenshot of lots of different things that have come out over the last couple of years or so, year and a half. A very interesting time, I think, for lipid management. Lots of things happening. So just briefly, the guidelines that came out actually in the fall of 2018, and then a little bit of an update since then. There's a little bit of a decision tree here. And let's see, I think well, okay. So anyway, this is kind of an overview. And then we talk about lifestyle changes. It's a little bit frustrating in a way because somebody goes on a super good diet and their LDL goes down by this much, but it just is what it is. I always tell my patients that diet will do things that the medications can't. There's probably reduction in cancer. There's probably reduction in diabetes by doing the right thing with regard to lifestyle, diet, exercise, et cetera. So that's always good. There are these things called risk enhancing factors. I don't know if I like that term, but there are things that will make your risk bigger. And those are important to be aware of course, family history, primary hypercholesterolemia, don't worry about that. That's a technical thing that there's a lot of controversy about. But metabolic syndrome, we do know about that. I think everybody's well aware of that. Central obesity, insulin resistance, high triglyceride, low HDL. Chronic kidney disease, oftentimes we forget that somebody with CKD is at actually great increase in risk of cardiovascular disease. Chronic inflammatory conditions like rheumatoid arthritis, lupus, et cetera. Other risk-enhancing factors. This top bullet is a very important one. We as non-gynecologists are guilty of kind of ignoring the whole history about menopause, the timing of menopause. The earlier, the higher the risk, whether it's surgical or natural. And then pregnancy-related conditions. Anybody with a history of preeclampsia has a greatly increased risk intuitively, but again, I think we forget to ask, what about gestational diabetes? Those things we really have to include in the history taking with any female patient. Mention was made a little bit earlier about high-risk race and ethnicity. The 2018 guidelines have finally addressed the issue of South Asians being at elevated risk. Please pay attention to that. East Asians also. So I'm talking Chinese, Japanese, Korean. I would also say Southeast Asian. We don't have as much data, but I think anybody from Vietnam or other countries, we have a lot of people from those countries in the US. And then also I would include the Filipinos. Now we don't have any reasonable data about them, but I think that it is likely that really most of East and South Asia and Southeast Asia is at increased risk. Now we talk a lot about Hispanics and they are at increased risk, but you know this, Hispanics are everything from A to Z racially, right? You've got somebody 100% Caucasian, 100% African, 100% East Asian. I mean, it can be anything. So it's really, I think, the admixture of Native American blood that does pose an increased risk. Middle Eastern, this is something we're just now waking up to, but folks from the Middle East, you know, north of the Sahara in Africa and then the Middle East tend to have an increased risk. And then not listed here, but of course, folks of African descent have way higher risk, as you know, of hypertension and chronic kidney disease, also along with that, stroke in particular, but cardiovascular disease in general, peripheral arterial disease as well. Okay, there are other things that we're testing now, maybe HSCRP, Lp(a), ApoB, ankle brachial index. We're gonna hear a nice lecture in a little while, I hope, about lower extremity athero. Coronary calcium score, I hope you're all familiar with this. This is not perfect, but it's excellent as a non-invasive measure of risk. And in Salt Lake metro area, I know you're not all from Salt Lake, but those who live here, we have about the cheapest chest CT in the whole country at $69. People usually have to pay out of pocket for that. Now, we have something new called high-risk ASCVD. So somebody with a prior event, but who meets some of the criteria here at the top, at least 2 of these or 1 of these plus 2 at the bottom, qualifies as having especially high risk. So secondary prevention has now been divided into higher risk and lower risk. I think that's an important concept to keep in mind. On the left-hand side here, we see those who do not have quite as high a risk, but there's still secondary prevention. Some good information here. I'm not going to take time to go into it. And then very high risk. We're, of course, going to be much more aggressive in treating these people. And I'm going to talk briefly now about LDL lowering, but of course, statins aggressively, ezetimibe, PCSK9 inhibitors, and then I'm going to add some new data here in just a second. But the bottom line is, this is so important, please do your best with statins. Don't give up on statins too early. Oftentimes, a little extra encouragement on the part of the clinician will help the patient go back and try statins again, or at least go back to a lower dose or something. Do whatever you can do with statins. They're just such a great class of medications. Now, what about statin adjuncts? Well, on the left-hand side here, we have positive trials. On the right-hand side, negatives. And there's something that positive studies have in common, and that is that it's extra LDL lowering. So we've got ezetimibe, and then the 2 PCSK9 inhibitors, evolocumab, which is, of course, Repatha, and alirocumab, which is Praluent. We've got very good data there, and we have no excuse to leave LDL too high. The kind of one-size-fits-all goal for LDL is less than 70, but we want to be more aggressive than that, like down to 55 or 50 or so in the very high-risk secondary prevention individuals. Now, we've got a brand new drug for LDL lowering, just approved a couple of months ago, just barely became available, called bempedoic acid. The trade name is Nexletol. And what you have here is a little cartoon that gives us some perspective. Here are good friends of statins, right here in the middle of the slide. They, of course, work on HMG reductase, and they're unfortunately active in the skeletal muscle, so we tend to have skeletal muscle symptoms in many patients. Look to the next row up, and you see bempedoic acid, which works at a higher point in this cholesterol synthesis chain, but it has the same impact, but it's additive. So if you give somebody statins and then add bempedoic acid, you get additional drop in the hepatic cholesterol, additional increase in LDL receptor, additional drop in LDL cholesterol, plus bempedoic acid as a bonus is not activated in the muscle. So as best we can tell, we don't have muscle symptoms there. Now, how effective is it? Well, it's not as effective as we'd like it to be, okay? It's roughly in the same neighborhood as ezetimibe, which is, 18, 20% or so. But it does have on the right-hand side here some extra drop in hsCRP, which we think is helpful. Statins, of course, do that. Ezetimibe does that. So that's all good. So the LDL cholesterol lowering is modest, but remember that this is the same as this 18 to 20% is about the same as 3 doublings of the statin dose. That's an 8-fold increase in statin dose. That's impressive. It's additive to ezetimibe. It's a little bit better if the patient's not taking a statin. Of course, the only patients not taking statins are those who are truly statin intolerant after we've done our best. There's now pretty good payer coverage, even though it's brand new. I'm going to say that it really is our third line after statins, then ezetimibe, and then bempedoic acid. Now, I know we like the PCSK9 inhibitors. They're fabulous drugs, but they're a little hard to get, and I think bempedoic acid is coming in now as a more reasonable third line. There's some safety stuff just to be aware of because it's a brand new drug. Uric acid levels can go up. You can trigger gout in somebody with a prior history. It's not very common, but there is a slight increase in risk of tendon rupture. So just be aware of that. There's some drug interactions. So the quick answer here is we do not go above the top. We do not use the top dose of either simvastatin or pravastatin. Now, we don't use those drugs very often, but do not use the top dose of those drugs with bempedoic acid. There's an adverse interaction, okay? Now, there's a new drug that isn't available yet, but should be available second half of this year. It's called inclisiran. It is like the PCSK9 inhibitors, but instead of twice a month, it's actually twice a year. Very cool. My guess is that this will probably insert before the PCSK9 inhibitors, although one very important thing is that the cardiovascular outcome data are ongoing, as they are for bempedoic acid. We do not have CVOT data for either bempedoic acid or inclisiran, but I think we're going to use them as if they would work because it's just so likely that they will, okay? Now let's shift gears quickly to the triglycerides. This is a very interesting curve. If you can see the numbers there at the bottom, that's a triglyceride, a fasting triglyceride of 100. There is 200, and here's the risk of cardiovascular disease. Most of the action is actually before you get to 200. We have a problem here, and the problem is that we're neglecting mild to moderate triglyceride elevation. Do not ignore the patient with what looks like a normal triglyceride. If it's above 100 or 135 or so, don't brush that patient off. Do your best with LDL lowering, with the statins and the other drugs I just mentioned, but remember that a patient at high risk with a prior event or diabetes plus other risk factors, they have a huge risk, and we have excellent data. You know these data, so I'm not going to spend much time on it, but on the left-hand side, the primary endpoint in the REDUCE-IT trial, which was icosapent ethyl. It's pure EPA, it's fish oil, but it's prescription fish oil, 4 capsules a day, huge 25% drop. And the primary endpoint, 26% drop, in the secondary endpoint, 30% drop in total events. This drug is really game-changing. This is a paradigm shift. We're no longer just entirely focused on LDL. We have to think about the high triglyceride patient, because otherwise there's going to be all this risk that we could have prevented that we did not bother to do. Now, in deference to our first speaker, there's a little atrial fibrillation that comes in here. It's not a huge problem, but it does occur a little more often with icosapent ethyl than with placebo, so just be aware of that. The EP docs that I've talked to said it's no big deal, so that's what they say. I worry a little bit. If you have a history, there's a little more likely, of course, that would make sense. This thing in the middle is, FDA is a little wacky, frankly, to put this in, because there's never been allergic reaction to icosapent ethyl. There's no such thing, but they put it in just in case somebody's fish allergic, not shellfish allergic, but finfish. Okay, be careful. Bleeding, this is a feature, not a bug. The antiplatelet effect of IP is part of how it works. So just realize that it's kind of like a mild antiplatelet agent, but with way less risk of bleeding than aspirin or the higher tech antiplatelet drugs. This just shows you that this is not the only trial, REDUCE-IT, not the only trial with icosapent ethyl that works. Jealous and other trials showed the same benefit. And if you look at all the omega-3s, the only ones that showed benefit are Gellus in the purple here and Reducit in the bottom, and those are the only two that are pure EPA. So if there's evidence that somehow DHA is a bad guy, here's Strength. Now, Strength was a trial I was sure it was going to work. In fact, if you talked to me, I would have bet you dinner that Strength was going to show benefit, and it didn't. Strength was very similar to Reducit, but it had some DHA added to the EPA. So somehow DHA seems to be a bad guy. We do have an ongoing trial, Prominent. I'm involved in that one. Very interesting. It's a successor to fenofibrate. May show benefit, may not. We just don't know. Lots of new guidelines have come out since Reducit, basically all saying the same thing. Please take a patient with a triglyceride of 135 or 150 and higher and seriously consider adding icosapent ethyl on top of whatever you're going to do with the LDL lowering. Okay, so do your best with LDL and then look at triglycerides. If it's elevated, treat with icosapent ethyl. What happens to the triglyceride doesn't matter. It doesn't have to go down. Just use it. It'll work. So here's my last slide. We have across the top here optimized statin therapy, then we had ezetimibe, new little figure ought to go in here, bempedoic acid, and then the PCSK9s, right? But down here, we've got to remember that with optimized statin therapy, adding icosapent ethyl, pure EPA, not the dietary supplement, there's no over-the-counter, prescription icosapent ethyl joins this elite club of drugs with good data. Thank you very much for your attention. Appreciate the time.
Okay.
Sorry, so I think you were on mute there for a second.
Okay.
I don't know if you were asking a question at the beginning, but you were on mute for a second.
Okay. No, I'm not asking a question. I was just thanking Dr. Brinton. And I said, if any of the audience, they have any question, please raise your hand or write a question in a chat box. So it's my turn now. I'm going to give a talk as Dr. Brinton was talking about ABI as one of the risk factors in deciding in terms of primary prevention, which patient we need to start on statins. So can you guys hear me? Beat, can you hear me?
Yes, you're loud and clear.
All right. So why every physician must diagnose PAD? I have no financial disclosures. Again, please share your experience, thoughts, suggestions at my Twitter, Doc Cards. You can always approach me. This is a scene from one of my all-time favorite movies. All right. Can anyone guess which movie is that? So it's Dancing with Wolves.
With the wolves.
Yes, with the wolves. One of my all-time favorite. So if you look at the Medicare data, about 50% of patients who undergo amputation because of the vascular issues, they don't even get vascular evaluation. And according to one of my mentor, Dr. Walker, for some reason, it is considered a conservative treatment to chop someone's leg off, an aggressive treatment to even perform an angiogram. Nearly half of the individuals who have amputation due to vascular disease, they will die within 5 years. And this is higher than 5 years mortality rate for breast cancer, colon cancer, or prostate cancer. Of person with diabetes who have lower extremity amputation, up to 55% will require amputation of the second leg within 3 years. And amputation is just not any other surgery. It has very high perioperative morbidity and mortality. 40% of them are dead within 2 years, and the quality of life is worse than lung cancer. So we need aggressive limb salvage. So let's talk about this patient of mine who was referred to me from Tuala. He's a 67 years old lady with tobacco abuse history. She had a very small bunion removal surgery at a podiatry office. And at that time, her ABI was 0.8, which was, mildly abnormal. But then 4 months later, after that small bunion surgery, she came up with this. You could see the tendon, through the skin, and severe pain. So just based on the history and what I saw on the ulcer, I took her to the cath lab. As you can see on the left side, complete occlusion of the SFA popliteal. She underwent balloon angioplasty and stent, and trying to go to the next slide. All right, so this is after intervention. Now you can see 3-vessel runoff. So she underwent aggressive wound care therapy, and 2 months later, she went on to heal that wound, and we prevented amputation. So what is PAD, peripheral arterial disease? It's the presence of stenosis or occlusion in the aorta or arteries of the limbs. It's one of the 3 cardinal manifestations of atherosclerosis in addition to CAD and CVD. So that's why patients with a PAD, they also have increased risk of cardiovascular and cerebrovascular events like heart attack, death, and MI, and stroke. Prevalence, if you look at the patient, if they are more than 70 or if they are patient 50 to 69 with either diabetes or smoking, the incidence of PAD can be as high as 30%. And even without diabetes, if they are more than 65, the incidence can be 20%. So it's a fairly common disease. And of 2 million people who live in the United States, very minority of those patients are actually getting diagnosed and treated. If you look at the 10-year survival rate for patient with a PAD, if you look at the normal patient, their curve. So if you have a patient, even if they are asymptomatic, no ulcers, no pain in the leg, but if they have abnormal ABI, their mortality curve is worse than normal subject. And if you have severe symptomatic PAD, that's even worse. So why should we all fear PAD? It's just like cancer, it's progressive. It's mostly asymptomatic. By the time you diagnose it, it's usually too late. And it has significant morbidity and mortality. And the incidence, the numbers of PAD patients are increasing because of aging population and increasing diabetic population. So just like we do, screening tests for cancer, the same thing should be done for PAD as well. Clinically, PAD severity can be mostly they're asymptomatic, 20 to 50%. Again, as I said, even if they are asymptomatic, their mortality is high. Their symptoms they can have mild, claudication, pain in the leg when they walk. When they rest, the pain goes away, or they can have atypical claudication. Critical limb ischemia, which is the far end spectrum of PAD, although it accounts for only 1 to 2% of population, but these are the patients who are mostly symptomatic, either with ischemic rest pain or they have tissue loss or ulcers. And although it accounts for only 1 to 2% of these patients, but if these patients, they don't get intervened on, if they don't get intervention, they will lose their limbs. And not only that, patients with critical limb ischemia at 1 year are alive with 2 limbs, their chances are 50%. There's 25% risk of amputation at 1 year, and cardiovascular mortality is 25%, which is huge. So what should we do with these patients when they come to us in the clinic? The first thing I always ask, even if these patients are coming with leg pain and ulcers, the first thing I ask is about their history of CAD, chest pain. Even if they have kind of iffy atypical chest pain, my threshold for ordering some sort of non-invasive testing is high on these patients. These patients need complete overhaul of their lifestyle, tobacco cessation, diabetes control. Use of aspirin or Plavix in these patients can reduce risk of CV events. Use of statins in these patients can not only decrease their risk of amputation, but it also improves mortality in these patients. These patients need prompt podiatry referral, wound care referral. And these patients always needs to be examined with their shoes and socks off. They can have thin, dry, shiny, or hairless skin, or their nails may become brittle, hypertrophic, and rigid, and they may have cooler extremities. And if they hang their feet and if they have skin discoloration like this on the left side, this is called dependent rubor. This is an ominous sign. This means that these patients need urgent revascularization. If they come in with ulcer, just look at the ulcer. The ulcers are dry, punched out, painful, exhibit less bleeding. Most likely it's because of arterial insufficiency. Compare these ulcers to the venous ulcers, which are usually larger, exudative, less painful, and they're associated with either edema or varicose veins. Moving on to ABI testing, again, great, great screening test, very fast, inexpensive. It can be done in any primary care office or NP office. However, it is difficult to perform in the setting of limb wounds or ischemia. And if you look at the numbers, usually the ABI between 0.9 and 1.3 is normal. More than 1.3 is also abnormal, non-compressible because of calcification. 0.4 to 0.9 is mild to moderate disease, and less than 0.4 is severe PAD. And it is the ABI testing. It's part of the guidelines. ABI should be done in a symptomatic patient with leg pain or with non-healing wounds. But even if the patients are asymptomatic, if they are aged more than 65, or if they are more than 50 with history of smoking or diabetes, ABI should be done. As Dr. Brinton said, it can be one of those risk factors based on which you decide whether to start someone on statins or not. But don't rest your hat on the ABI only. Why? Because calcification can cause false elevation, and most of these patients are diabetic. They have a lot of calcified vessel, and ABI does not take into account the angiosome concept. So now what is angiosome concept? Just like in the heart, we have the arteries like the LAD, which supplies the anterior wall, RCA supplies the inferior wall. It's the same in the legs as well. The dorsum of the foot is supplied by the anterior tibial artery. The plantar surface, the heel, is supplied by the posterior tibial artery. For example, in this patient, if I do an ABI on the posterior tibial artery, most likely it is going to be normal. But if you look at the ulcer is present on the dorsum of the foot, and when the angiogram was done, there was complete occlusion of the anterior tibial artery. And this is what this patient needs. This patient needs intervention of the anterior tibial artery, which is supplying the anterior tibial angiosome, which is the dorsum of the foot. TBI, the toe brachial index, is a better test than ABI because you don't have a lot of calcification in the arterioles of the toe. The absolute pressure of more than 30 is favorable for wound healing. However, again, this test can be difficult to perform if someone already has wound. Segmental pressure demonstrates level of arterial disease. Again, difficult to perform in the setting of critical limb ischemia. TCPO2. Let's move on to arterial duplex, which is the mainstay of non-invasive imaging. It gives us both info about the arterial anatomy as well as hemodynamic information. It's heavily tech dependent. It cannot really evaluate more proximal iliac vessels. Again, difficult to perform if someone has wound, their legs are wrapped. CT angiogram can accurately assess the arterial anatomy. However, it has contrast-related issues, especially in someone who has abnormal kidney function. And it really does not specify below the knee vessels because of either poor cardiac output or calcification. And most of these patients with wounds have below the knee vessels, below the knee disease. MRA is a better test than CTA. However, it is not available everywhere. It is expensive, and it also has some contrast-related issues. Angiography is invasive. It's a gold standard test. It allows for immediate intervention at the same time. Again, it's invasive. We also give contrast, especially in someone with abnormal kidney function. It can be a problem. However, we can use carbon dioxide in those patients with abnormal kidney function without using contrast. So let's talk about this case. Again, 82 years old, gentleman coming in with non-healing ulcer. He has history of hypertension, CKD, diabetes, painful, poor pedal pulses, cooler extremities. Again, typically based on my exam, it was very typical arterial case. So because of abnormal kidney function, in order to save some contrast, we did a CO2 angiogram. As you can see, common femoral, profunda, SFA, all normal. But if you look distally, there was complete occlusion of the SFA and popliteal. So I tried to cross it from above, could not because of a lot of collateral. So I put a sheet in the foot, in the pedal artery, went backwards, snared the wire, was able to do balloon angioplasty and stent. And you can see right on the table the change in the color and the temperature of the right foot compared to the left foot. Now the right foot was well perfused, and he went on to heal this wound in 2 weeks. 58 years old, another case, a lady who had a knee surgery, and 4 weeks after her knee surgery, she came up with these wounds. And I published this case report a few years ago. So again, based on my exam, poor pulses, uh, painful ulcers, I knew this was arterial. We did a sensorless test or a skin perfusion test, which was abnormal in the right leg as well. So we did the angiogram on this patient, and right above the knee joint, there was a complete occlusion of the popliteal artery. Most likely this happened because of the surgical complications. So we went in, we did a balloon angioplasty. I did not put a stent behind that knee joint, and you could see 3-vessel runoff after that intervention. She underwent extensive wound debridement and some skin graft, and finally, after months, she went on to heal that wound. Another patient, 79 years old gentleman with abnormal kidney function. He had previous left foot amputation due to PAD, and now he's coming in with right foot ulcers, with osteomyelitis, resting pain, poor pulses, again, critical limb ischemia. So as you can see, the ulcers, now just looking at this foot, I know which artery in the leg is involved. This is the posterior tibial angiosome. So I did the angiogram to save some contrast. I did the carbon dioxide. As you can see, the aorta, the right iliac, the left iliac, the SFA, they're all normal here. Now you see that the normal AT, peroneal, posterior tibial. But when you go all the way down to the foot, here you can see the anterior tibial is completely occluded. The posterior tibial is completely occluded. So again, based on the angiosome concept, I know this is the posterior tibial. So I went after the posterior tibial artery, went all the way to the pedal arch. And he went to the OR, and after some surgical debridement of that wound, you could see the blood flow. And this is exactly what we want to see. We want to prevent further amputation, and we want good blood flow all the way to the toes to heal this wound. So moving on to the next slide. All right, so stop the chop. Amputation without vascular evaluation happens too often. We should identify them earlier, refer earlier, treat earlier. And non-invasive testing is far from ideal in these patients like ABI. And individuals with PAD have an exceptionally elevated risk for cardiovascular events. And the majority will eventually die of cardiac or cerebrovascular etiology. And general practitioner, PCPs, PAs, NPs must be engaged in the diagnosis and management of PAD, because it can be life-saving. Again, it's a team approach. There should be a close communication between vascular specialists, nephrologists, podiatrists, nurses, and imaging specialists. Again, if you guys have any question, feel free to reach out to me, email me, or follow me on tweet. And within the next 2 to 3 months, we'll keep doing these webinars. So the best way to know which webinar is coming is to follow me on tweet or email me. Thank you very much, guys.
Great cases. That's it seems to me, and perhaps this, I hope it's not as nationwide as this, but I feel like a lot of areas do not have a comprehensive PAD program, both on the front end of assessing and treating, and then on the back end where we, it seems like PAD is the stepchild. I hate to say the stepchild, but it's not given enough importance in cardiovascular risk. So thank you for sharing that.
Thank you. So next up is updates in heart failure management by a very good friend of ours, Dr. Lynn Cameo from University of Utah Cardiovascular Division. Dr. Cameo, are you there?
I am. Good evening, everyone. Thank you for having me. And I'm going to try and share my slides here. Okay. All right. Can you guys see my slides?
Yes, we can.
All right. Thank you for having me. And I'm Lynn Kimiyu. I was asked to talk about the novel therapies in heart failure management, specifically medical therapy. I do not have any disclosures. And here is my outline. And I'm hoping at the end of this presentation, we will all be able to state indication and contraindication for use of sacubitril/valsartan in patients with chronic heart failure, as well as contraindication and indication for use of the sodium glucose cotransporter 2 inhibitors in patients with chronic heart failure. I think I've figured out we should begin many decades back where it all started. If you look at the history of heart failure here, from the 1940s up until the area before the 1980s, prior to 1980s, the focus really of treatment of heart failure and cardiovascular disease was directed at lifestyle modification, limitations such as bed rest, inactivity, and fluid restrictions. And with medication used with digitalis and diuretics were really the mainstay of treatment at that time. So the 1990s really marked the beginning of what was called a pharmacological era. We continue to use digoxin and diuretics, but with the VHF trial, there was a focus with use of oral vasodilator, particularly the combination of nitrates and hydralazine. And also there was a prominent role of inotropic support during that area. Fast forward into the 1990s, which was somewhat of a continuation of this pharmacologic era, there was a focus on neurohormonal intervention. And these were shown to alter the natural history of disease progression. And at that point, it was shown that if you could take a patient with heart failure and in fact begin to attenuate the progression of the illness and not just take care of the symptoms. For example, with the beta blockers, it was shown to partially improve the pumping capacity of the heart and not just delay the progression of heart failure. And with that, we could change the natural history of heart failure. And fast forward 10 years into the 2000s, we continue to investigate other drugs as well as device. So as we continue to learn that we could stop the disease in its progression, we still were faced with a problem. In selected case of patient, the heart will begin to fibrillate and cause sudden cardiac death. And with that in Europe, we saw a change with emphasis on placing implantable cardiac defibrillators in patients to prevent cardiac death. So all of those interventions changed the natural history of heart failure in a positive way, in such a way that we were able to save lives. We also saw continuous studies focused on stem cells, even though the results were not as exciting. So going into the 2010 and moving forward, we saw continued improvement with left ventricular assist device, and also newer drugs came into the market, and all of this to continue to improve the mortality and morbidity. So I'm going to shift gear here and focus on some of those drugs that have recently came to light, particularly the angiotensin receptor neprilysin inhibitors. I think it's important to understand the mechanism of those medications. How do that work? So these medications are known on the market as LCZ 696. Some of you may have seen commercial on TV with Entresto. So this is an angiotensin, a combination of an angiotensin receptor antagonist, valsartan, with a neprilysin inhibitor. So we have valsartan plus sacubitril that sort of exercise a suite of actions to bring together antagonism of the vasoconstrictive system on one hand, and on the other hand, you have upregulation of or promotion of the natriuretic peptide system. So the angiotensin 2 type 1 receptor inhibitor delays the progression of vasoconstriction, reduces sodium and water retention, delay fibrosis, hypertrophy. And while on the other end, with the neprilysin inhibitor, you have upregulation of the neprilysin inhibitory activity, leading to prevention of breakdown of natriuretic peptide, eventually leading to vasodilation, natriuresis, diuresis, and inhibition of pathologic growth. I think it's important to point out that sacubitril is a prodrug of the neprilysin inhibitor. Once it gets activated to his active form through an esterification process, the active form called the LBQ657, that enzyme is responsible for the breakdown of a number of vasoactive substances, including the biologically active natriuretic peptide, such as ANP, BNP, and CNP, as well as other vasoactive substances such as bradykinin, substance P, and adrenomedulin. Also angiotensin too. So you can see that with valsartan inhibiting the angiotensin, let me rephrase that. With the upregulation of angiotensin 2 via the LBQ657 pathway, represented here at the bottom, we do know that the angiotensin 2 would eventually lead to vasoconstrictive effect. But by introducing valsartan with that combination of the LCZ696, you have inhibition of that upregulation of angiotensin 2, eventually leading to blocking the downstream vasoconstrictive effect. So it looks like this is a very good combination of action that might be beneficial in heart failure. And to prove that, we had a study, the Paradigm Heart Failure Trial, which was actually the largest trial ever done in heart failure, 8,400 patients, comparing LCZ696 to what was viewed up to that point as a state-of-art or standard therapy with enalapril in the management of patients with heart failure with reduced ejection fraction. So the hypothesis was that patients with taking LCZ696 would benefit to a greater extent than what was known as a standard therapy with enalapril. So patients went through a run-in period, which was really done to maximize the dose of medication and make sure that patients were tolerated either one of the drug, either the comparator, SCZ96 or enalapril. So they were then randomized to receive a maximal dose of LCZ696, 200 milligram twice a day, or enalapril 10 milligram twice a day. And these patients were followed for a median of 27 months. The primary endpoint was the composite of cardiovascular death or heart failure hospitalization, which is shown here. The study showed that there was a 20% reduction in the combined endpoint of this primary endpoint and a 21% reduction in heart failure hospitalization. So this is a summary of the Paradigm trial. And this, based on those findings, it made its way to the guidelines where recommendation for ARNIs, ACE inhibitor or ARB to reduce morbidity and mortality in patients with chronic heart failure with reduced ejection fraction. And that also patient with New York Heart Association class 2 symptoms who were already on a tolerable dose of ACE inhibitor on ARBs should be transitioned to an ARNI to further reduce mortality and morbidity. And this was a class 1 indication. So we've seen really advances over the past several years in management of patients with heart failure with reduced ejection fraction. But we haven't seen as much of a progress in an equally important class of group of patients, that is the heart failure with preserved ejection fraction. And I think, as you guys are all aware, this is a group of patients that constitute a large proportion, 50% of patients with heart failure. So if you think about this, close to 60 million of patients worldwide living with heart failure. So think about half of those patients a very large group of patients with unmet needs. And it's not really because we haven't tried to find additional treatment or treatment for that selected group of patients. We just haven't been successful. There were trials looking at the benefit of ARBs and also mineralocorticoid receptor blocker, but we just haven't been successful in terms of meeting primary endpoints. And to really highlight how that particular group of patients, the HFpEF, is relevant, my colleague Kevin Shah actually sought to characterize differences in outcome in patients hospitalized with heart failure with preserved ejection fraction, that is an EF greater than 50%, patients with borderline reduced ejection fraction between 41 and 49%, and the heart failure with reduced ejection fraction less than 40%. Kevin Shah collected data from the Get With the Guideline Heart Failure. This was a large pool of patients of more than 39,000, and he looked at the 5-year outcome in those group of patients with heart failure, and these were patients admitted for heart failure between 2005 and 2009. And it was shown that across the ejection fraction spectrum, these patients had a similar poor 5-year survival with an elevated risk for cardiovascular and heart failure admission. Again, this data shows and findings highlight really the need to improve treatment of patients with heart failure with a preserved ejection fraction. So we've seen positive results with the paradigm heart failure trial. So the question was, with the LCZ 696, would we have the same benefit in the heart failure with preserved ejection fraction? So this was looked at with the Paragon heart failure trial, which was designed to compare sacubitril valsartan, LCZ 696, in the group of patients with heart failure with preserved ejection fraction, to see if we would have the reduction rate of composite endpoint of cardiovascular death and the heart failure hospitalization in patients with ejection fraction greater than 45% and NYHA class 2 to 4. This was also a decent study in terms of patient population, 4,800 patients. And these patients also, after having undergone a running period and randomized to either LCZ 696 or valsartan, these patients were followed for a median period of time of 35 months. So in terms of looking at the composite endpoint, primary endpoint, it was noted that there was a 13% non-significant reduction in the primary endpoint of heart failure hospitalization or cardiovascular death, and the p-value here was 0.059. So moving forward, I'm going to shift gear here. The Paragon trial showed that overall, while we did not see a significant overall benefit, but we did see that in a selected group of patients, these were the female patient, and the patient who was sort of at the lower end of the median median ejection fraction below 57 in the study, there was perhaps a benefit from LCZ 696. So moving along, this is a summary of the Paragon heart failure trial as illustrated on this slide. And so I'm going to shift gear here and talk a little bit about the cardiovascular effect of diabetes medications. I think, as we're all aware, type 2 diabetes is a major risk factor for cardiovascular disease. And a large proportion of patients with heart failure also have type 2 diabetes. 2008 in the world of anti-hyperglycemic medication was a very defining year, because prior to that, diabetes drugs were being approved, yet we did not have much information on the cardiovascular risk and effect. So in 2008, a regulatory agency came together and created and provided guidance and highlighted that every new anti-hyperglycemic agent will be required to demonstrate cardiovascular safety. So it wasn't up until 2016, we had no diabetes therapy that had a claim or indication for cardiovascular risk modifications. And there were several trials ongoing with the DPP-4 inhibitors, the GLP-1 receptor antagonist, and the SGLT2 antagonist. And with the DPP-4 inhibitor, the results weren't really very exciting up until the SGLT2 antagonist came into light, and they really moved forward the needle with cardiovascular efficacy. So how do these medications work? So the soluble sodium glucose cotransporter is a molecule that is found at the proximal tubule, and it is responsible for sodium and glucose reabsorption at the level of the proximal tubule. So by inhibiting this receptor, and it leads to a cascade of pharmacodynamic effect, including osmotic diuretic effect with the inhibition of reuptake of glucose from the filter urine. So this class of drug have a glucosuric effect by increasing urinary glucose excretion, therefore, and by doing that, they lower blood glucose. And also there's a weight loss also reported by that mechanism of increased glucosuria. So when you're excreting glucose, you're also excreting calories. So these drugs have been associated with weight loss. It's been reported at about 10 to 12 pounds of weight loss over a period of 1 to 2 years. Also, these drugs also affect adipose tissue by increasing lipolysis. And with that, there's a reduction in inflammatory and oxidative stress. As you all know, heart failure is an inflammatory process. They do have also a blood pressure lowering effect, 3 to 5 millimeter of mercury on average. At the level of a kidney, there's reduction in albuminuria and slowing of the progression of renal disease, as well as expansion of red cells mass through stimulation of erythropoiesis, leading to increase in the circulation of hematocrit level. There's also some benefit in terms of ketogenesis, which may be a preferential energy source for the heart, as well as looking at the level of the blood vessel, modulation of endothelial function, and a sympathetic tone. In the middle here, there's also been reported that the SGLT2 inhibitor inhibit the sodium, lead to inhibition of sodium hydrogen cotransporter, therefore leading to an effect on the intracytosolic calcium concentration, perhaps modulating the risk of sudden cardiac death and arrhythmia. So this was further, with this broader pharmacodynamic effect of SGLT2 inhibitor, we took it a step further and looked at the effect of those medications with the trial called the EMPIREC trial. This trial was published in 2015. It was the first time in the history of diabetes that a clinical trial was positive for an important clinical outcome. It demonstrated that there was a 14% relative risk reduction in cardiovascular death, MI, and stroke. And this was a very important observation. A stunning result because we've never seen that before. The 14% relative risk reduction was largely driven by the effect on cardiovascular death represented here. I think it was 38%. So this study actually had a lot of scrutiny because the results were stunning, and stunning to the point that people just didn't believe it. But eventually, in December of 2016, we all realized that this was a real findings. So this led to the FDA granting a product label indication, the first drug in the history of diabetes to have a label has an indication to reduce clinical risk. importantly, with the EMPEREC trial, we also show a signal for lower risk of heart failure hospitalization, 35% we presented at the bottom here. And so we took it the next step, I think, with this signal that we saw with the EMPEREC trial towards heart failure hospitalization. We took it a step forward to look at that in a broader trial. This was the DAPA-HF trial, and this was a pretty simple trial that looked at studying dapagliflozin and in patients with heart failure with reduced ejection fraction. And the trial enrolled about a little bit over 4,700 patients, and these patients were followed for a median period of time of about 18 months. And it is important to point out that these patients was on very well established pharmacological therapy for their heart failure management. And we presented here the inclusion criteria. NYHA class 2 to 4, 67%. Average ejection fraction was 31%. And as I mentioned, these patients were on very good heart failure medical therapy. So moving on, the primary endpoint was the composite of worsening heart failure or cardiovascular mortality. And this study demonstrated that there was a 26% relative risk reduction in that primary endpoint. And both of the component, if you look at the primary endpoint of cardiovascular death and heart failure hospitalization, you will see that represented here on the top upper corner, the heart failure hospitalization was demonstrated as a 30% reduction. So this was an important finding from the DAPA-HF trial summarized here that really showed that there was an observed significant clinical reduction in worsening heart failure and in cardiovascular mortality. And it was also shown that this benefit was seen in all of the major subgroup that was looked at of this patient population, heart failure with reduced ejection fraction, whether you had diabetes or if you did not have diabetes. And the study also highlighted the fact that this was a completely new approach for the treatment of heart failure with reduced ejection fraction, perhaps a shift from no hormonal intervention towards a completely different path. So this led to the ESC guidelines in 2019 recommending SGLT2 inhibitor as a first-line treatment of diabetes in heart failure patient, and also taking it a step further. About a month ago, the FDA approved DAPA for the treatment of heart failure with reduced ejection fraction in adults with and without diabetes. And I think one challenging one question that we have to ask ourselves is, with all those therapies coming out on the market, there's a lot of excitement, but how do we implement those treatments at the bedside to our patient? I think it's important to have a support system. And when we do take care of this patient during an inpatient hospitalization, I think discharge planning is really needs to be adequate to make sure that patients are really involved and understand what medications they're going home or they will be going home with. And I think ultimately it really requires a conversation. And for example, with the SGLT inhibitor, with DAPA, it's a simple drug, once a day, 10 milligrams. But I think the conversation should only not happen with the patient, but also with our peer professionals, and really understand what comes into play into implementing those therapy in this particular population. And as all of us are unfamiliar with this new drug, and also you can imagine how this could be an unfamiliar territory for this patient. And also be aware of some of the adverse side effect or potential things to look for or be mindful of in those patients when started on SGLT inhibitor. For example, be mindful of blood pressure and risk, for example, with the SGLT inhibitor, potential risk of perineal infection, and also with the particular class of SGLT with the canagliflozin, risk of distal amputation. So I think it's important to understand the medication, what system perhaps as a healthcare system do we need to implement to make sure that these patients are followed and patients understand why they're really taking these medications. I think for sake of time, I'm going to skip the next couple of slides here and just go to the conclusion. And significant progress in medical therapy. We've seen that in heart failure, we reduce ejection fraction in the past recent years. We've shown that ARNIs are very powerful, but yet there's work to do in terms of utilizing that therapy for heart failure. We reduce ejection fraction. And with the Paragon heart failure, we learned a lesson, that is that we still struggle to phenotype and treat this particular class of patient. And with the cardiovascular outcome trials, we've seen the light with the impact of anti-hyperglycemic medication on the cardiovascular system. So we should all be aware of the benefit of the SGLT inhibitor in patients with heart failure or at high cardiovascular risk. And there's still multiple ongoing clinical trial with that particular class of medication to enhance understanding of heart failure beyond the neuroendocrine hypothesis. I think it is a fact that guideline-directed medical therapy works, but I think it's also important to identify barriers that may preclude prescribing, acquiring, and implementing heart failure therapies. And one of those challenges being polypharmacy and cost. And with that, I will close my presentation. Thank you very much.
Thank you very much, Lynn. And one of the article that you quoted, the author of that article is in the audience. His name is Dr. Kevin Shaw. He is a heart failure specialist at University of Utah. Dr. Shaw, can you come online?
Hey, so I'm here.
Hey, Kevin, how are you?
I'm great. I'm great.
Do you have any input for our primary care physicians and our nurse practitioner referral base? Anything you want to say?
You know, I think Dr. Kemi, you did a fantastic job summarizing where we are now. And she, you know, even at the end, she mentioned Victoria, which is another trial that's demonstrated some positivity with vericiguat. The amount of drugs that we have for reduced ejection fraction heart failure, it's becoming a bit complicated now, and that we have so much that actually works. And I think it's all the more reason to have someone who sort of spends a lot of time taking care of heart failure patients involved as soon as possible, because between the costs and the interactions of these drugs, it's starting to really become its own space to have specialists help take care of these patients.
Great point, Dr. Shah. Thank you so much for being here. Next up is Dr. Mark Ibrahim. He is the assistant professor at University of Utah and associate director of cardiac imaging fellowship program. So one of my primary care friend, Dr. Andrews, he's also in the audience. I was visiting him a few days ago, and he asked me that when he orders a cardiac stress test, SPECT scan to a certain facility, it always gets converted into a PET scan. So he said, "Is there any difference?" So I said, I have my opinion. I gave him my opinion, but then I thought that I should get the expert who's fellowship trained in cardiac imaging. So Dr. Mark Ibrahim is here. Dr. Mark Ibrahim, can you start, please?
Hey, thank you, Sohail, for arranging this meeting. Can you hear me?
Yeah, I can hear you.
Just for some reason, I'm having issue sharing the screen. Let me see.
Viet, can you look at it?
Yeah, I'm gonna try. We're no longer sharing anything, so now all participants. So don't you all start sharing. Let's have
okay, when I'm hitting on the PowerPoint mode, when I'm putting share, it's not giving me the option to see the screen I wanted to share.
If you click on share screen, doesn't it give you a whole bunch of options?
Yeah.
And then you click on your slides?
Right, but I don't see my slides. I'm embarrassed about this. Sorry.
Close some other windows and see if the slides are there.
Yeah, that's a great suggestion, Dr. Brenton. It's crazy. Especially, I've got 3 screens running right now, so it becomes a quagmire of which one to share. That might be what's going on your screen there, Dr. Abraham.
Open system preference. 1 sec. I think there might be. Hold on 1 second.
Or if you are not able to share, we can start another talk. You can email me your slides and I can put it here.
Yeah, let me give it one final trial here, and then yeah, I'll move it till I may change computer. 1 second. Still, I'm not able to see my slides on the share screen. So maybe defer to the next speaker and I'll troubleshoot this. Would that be okay?
That's fine. That's fine. So let's move on to Viet. Viet is our co-host and co-chair for this program, and he has really helped me to put this together. He's a PA at Intermountain facility. He's also a faculty speaker at Rocky Mountain PA School. He's also a social media guru, but he's very smart, very heavy in research. So Viet, you can go ahead and start, please.
Okay. Well, I'm a little embarrassed as well, because just as I tried to start my video, it says my Zoom meeting is not responding, but obviously I'm on here. So it might have been when I tried to share, when I changed for Dr. Abraham. So let me see if I also can come. I might end up signing out and coming back in a different way here. So
Okay.
I apologize.
Yeah,
but in any
one
case,
other thought,
yeah.
do you know about those 2 little boxes at the bottom when you click on share screen? If you're sharing a video, it's helpful to check those 2 boxes at the very bottom.
Yes. Okay. I do see that. Unfortunately, my Zoom meeting has actually frozen. So that's odd. So I may drop out here and come right back.
That's fine. In the meanwhile, if any of the audience have any question, please raise your hand. I will unmute you and you can ask question to our faculty panel. To me, Dr. Cameo, Dr. Rizwan Khalid, Dr. Brinton.
So I've got a question for the last speaker. I'm kind of close to this as a diabetologist, lipidologist, but I'm really puzzled about these SGLT2 inhibitors. Each one has seemed to show something just a little better than the others. Empagliflozin maybe reduces cardiovascular death, maybe the other ones don't. But it turns out that canagliflozin has better data for stroke, whereas empagliflozin didn't reduce stroke. And then you've got dapagliflozin that has better heart failure data. Then you've got canagliflozin with better kidney data. Then you've got canagliflozin with worse amputation data. And I'm just wondering if you have a feel for whether these differences that seem to be there are real, or is it just kind of an artifact of the trial design, who they put in, what were their prior events, maybe play of chance in some cases. Do you have a sense for whether we should really pay attention to these possible differences among the SGLT2s, or should we just pick whatever the payer wants?
Dr. Cameo, are you there? Lynn, are you there? Dr. Britton, can you hear me?
Yes, so I guess what we can do is get that answer later. Looks like Viet's
Yeah,
ready
she
to
might
go.
have dropped off. And
Yeah, it's
okay.
okay. Let's continue the dialogue, and Viet looks like he's ready.
Go ahead,
Yeah,
Viet.
are you able to see my screen?
Yes.
Okay, so here we go. You know, I appreciate this opportunity that I've had to join in and co-moderate. Hopefully I haven't flooded you with too many chats there as we've been moving along. But I have the opportunity to do a little bit of an update on hypertensive management, and I'll follow Dr. Brenton's cues on how he ran the lipid management. In this case, it's not necessarily COVID related, so I'm appreciative of Dr. Khalid's comments on ACE inhibitors, ARBs as well in the COVID era. So hopefully you're seeing my screen there on cardiovascular updates. I represent the Association of PAs in Cardiology, and also I'm faculty at Rocky Mountain University of Health Professions. While I do have clinical duties, I will not mention them here as I need to be careful of my affiliations. So, here we go. Financial disclosures. Hopefully you can still hear me.
Yes, I can hear you. Yes.
Okay, good. Yeah, because my Zoom just froze again, but luckily you're seeing my screen. So,
Yeah.
I don't have any specific personal honoraria that have been given to me, but my research department has received travel reimbursements and honoraria from Amarin as I've given talks on EPA. And certainly I'm involved in a lot of research, sponsored trials, as well as investigator-initiated. However, one of my favorite trials that I have spoken on is Evaporate, as Dr. Brenton knows. Okay, so, you know, hypertension, it's such a big deal. Here we're not specifically asking necessarily about a disease sequelae, but you know, we're looking at these numbers and trying to give them a definition, as they are a risk factor for an end event. So it's a lot of numbers here, which, you know, we're recording. So hopefully we'll be able to give this back to you, and I can provide some of these slides in a slide deck. But, you know, we have 34% of US adults greater than 20 years of age. This is the pre-2017 guidelines. So when we're looking at stage 1 hypertension greater than or equal to 140 systolic, and diastolic greater than or equal to not 190, but 90. So, you know, following all of that, this is basically JNC 7 and 8 with regards to the epidemiology and prevalence. And so as we move forward into the 2017 AHA-ACC guidelines, the prevalence changes, because if you look up here, the systolic and diastolic blood pressures shift to stage 1 at greater than or equal to 130 and 80. So when that happens, you get from 32% to 46%. So we have this apparent sudden jump in diagnoses, and boy, you know, everyone's running around thinking, gosh, we just increased a whole bunch of people with the diagnosis of hypertension. Well, the definition changed, and that's true. We're recognizing these folks. I would argue that they were already at risk, and I hope to show that as we move forward here. So my short case for the adoption of 2017 AHA-ACC blood pressure guidelines versus those that do want to hold on to JNC 7 or 8. I know the European guidelines are a little bit different as well, but understand that the risk of cardiovascular disease doubles for every 20 millimeters of mercury of systolic and every 10 millimeters of diastolic over 115/75. So if you're using that as your baseline of normal and you're getting a 2-time risk of event, 135/85 is when you first double your risk. So then JNC 7 and 8 guidelines, stage 1 hypertension is 5 millimeters of mercury later, or both in systolic and diastolic. So it kind of leads me to think, well, okay, so we're starting or thinking about antihypertensive therapies after patients were already at risk. 2 times risk of CV events. And I think that it's just too late. So, you know, my favorite actor here, Ryan Reynolds, I will share his look of puzzlement and hope that you enjoy this as well, because I kind of look around thinking, wow, we're still going to accept this risk. But we didn't. You know, the SPRINT study came out. We were involved also as a site. And the idea and the question is, you know, intensive therapy, trying to drive blood pressure less than 120/80 versus standard less than 140/90, what would that do? I'm not going to report the trial results here, but just know that it led to those changes into the guidelines of 2017. So, you know, again, the short case, what about all these people who will be on medications though? Because, you know, suddenly we went from 32 to 46%. And my argument back is, we'll cover that, because the ASCVD risk calculator is one that we should use when considering initiating medical therapies. It helps us to really hone in, not just on the single number of blood pressure, but the other risk factors that fall in line with the outcome of interest, the coronary disease sequelae, the PAD sequelae, the stroke sequelae of hypertension. So meanwhile, while you're thinking about this, certainly a stage 1 hypertension definition of 130/80 really should help you promote early, promote always, promote now, lifestyle, lifestyle, lifestyle. So highlighting the difference again, JNC 7 and 8, it's a busy slide and apparently my animations didn't work here, but JNC 7 is right here. And you'll see over to your far left, these, you know, less than 120, less than 80, that's normal. Okay, that's fine. 2017 is the same. 120 to 129 and less than 80, however, was considered pre-hypertensive in the 7 and 8 guidelines. Now it's elevated blood pressure under 2017. You know, that's semantics, but it's still something to think about and hone in on. Finally, 130 to 139 systolic and 80 to 89 diastolic under JNC 7 remain prehypertensive. Now we have stage 1 hypertension. And I think, you know, what's in a name, what's in a diagnosis, when you give it, it becomes something more real and tangible for you and the patient. And I think that that's one of the important things that the guidelines did, the updated guidelines, is it helped to highlight that this is real disease. There's 2-time risk already occurring at this point. So, oh yes, my apparently my animation is going to work in backwards there. So let me just use a case scenario. I'm not this person, but 45-year-old Vietnamese male smoker presents for annual checkup. If you'll remember Dr. Brenton's talk on lipid management, you know, these are the Southeast Asians that may also be at risk for coronary disease. Past medical history, none's reported. Mother and father, as well as 4 older brothers and 1 sister, alive and well. This gentleman works as a construction foreman, married, current smoker, 1 to 2 alcoholic drinks an evening during dinner, participates in heavy resistance training, so is exercising, no current medications, but pay attention here. The blood pressure is 137/85. Heart rate, nothing to, you know, write home about. Saturation of oxygen, weight, height. One might argue BMI is a little high. And then labs were done a week prior. And you'll see a total cholesterol of 205, the LDL cholesterol 135, HDL 35, and triglycerides 145. And these are all important because we're going to look at the ASCVD risk calculator going forward. But when you look at this person, this is a usual, maybe you don't all see Vietnamese people, but this is a usual presentation. Someone that's coming in for an annual checkup. What do you do with that blood pressure? And what are you going to tell this person? Well, remember that under JNC 7, it's pre-hypertensive, but under the 2017 guidelines, this is potentially considered stage 1 hypertension. Of course, remember that we wouldn't, throw everything in on the very first visit, and there's more education to follow, as well as serial measurements. But what is the ASCVD risk score and this calculator that I speak of? You can see down below here, and just, you can Google it. Just open up a Google or Chrome or whatever your favorite internet search engine is. Look up ASCVD risk score, and you'll find the Risk Estimator Plus, which has been developed in collaboration between the ACC and AHA, but it includes these factors here, all of which were on that case slide of age, sex, race, lipids, current blood pressure, history of diabetes, yes or no, hypertension treatment, yes or no, and smoker, yes, former, or no. And all of these are then input to create a calculation. What you'll see here is that medication therapies in the guidelines should be considered for hypertension when the ASCVD risk is greater than or equal to 10%. So we'll come back to that. Hypertension diagnosis, therapeutic management. This is one of the central figures here. Well, it is the central figure for the 2017 update. And I want you to point to see here. I'll point out this middle section because this is JNC7 above. And as we move downwards, you can see a shift in the blood pressure from elevated to hypertension here, stage 1, when it was all under prehypertensive previously. Now, hypertension stage 2 combines everything previously as stage 1 and 2 under there. So again, further highlighting the risk that folks are already at when they get to 140/90. And as you drop down in this slide, this figure here, non-pharmacologic therapy, however, you get to the ASCVD risk score. So if they're hypertension stage 2, you may go ahead and go to blood pressure lowering therapy anyways. But remember, lifestyle. It's the first thing, and it should be the last thing. But in between, you should calculate whether your patient also has additional risk for coronary artery disease, necessitating consideration of blood pressure medication. So let's move forward then. In this case, we have this 45-year-old Vietnamese male smoker presents for the annual checkup, current smoker, right? Blood pressure 137/85, and here's the the lipid profile. Now, absent in here, so that you can answer this, is the age, male, other. The blood pressure we've input 137/85, total cholesterol 205, HDL 35, LDL is 135, and absent here is triglycerides. But I think Dr. Brinton did a great job of focusing our attention back on that. History of diabetes, yes, no, no. Smoker, current. On hypertensive treatment, no. Here, these two bars are just if you are looking at patients on a recurrent basis, and that'll help factor into the discussion later. But once this is all done, and if you've also calculated the risk, you see that this individual is 9.8%. I purposely put them in this funny no man's land or no person's land because I think most of us would think, boy, smoker, that's high risk. This blood pressure, though, if you're JNC7, 8 versus 2017, that you might kind of split the difference. This lipid profile may or may not intrigue you as much. Certainly, the triglycerides are greater than 135. So this person's kind of right there, and we have some room, certainly for lifestyle to take effect, and then a consideration of blood pressure as we move forward in this individual. I'll let you decide what you want, and maybe in the Q&A section we'll cover this. But I wanted to point out some of the pitfalls that we run into on a daily basis, and that Sprint kind of taught me as well, as our protocol was to repeat serial blood pressures on an automated blood pressure cuff. But if you only have one data point, are you ready to provide a lifelong diagnosis? We bring up the old wise people and the elephant, and if all you have is one data point, you're probably going to make some inferences that are incorrect or lead you in the wrong direction. And then also, I like this cartoon because I'm a patient advocate. my doctor's concerned about my high blood pressure. I told him next time, don't leave me sitting in the waiting room for 2 hours. You know, I teach this, and my any former PA students who are on the conference webinar here will see these slides and know that I'm really an advocate for speeding things up a little bit and not relying too heavily on a blood pressure that's done in duress. So avoid diagnosing hypertension by elevated blood pressure in acute illness, and recognize that there are other circumstances that are prevailing in each case. So other pitfalls here, I mean, a picture's worth 1,000 words. This is a great paper that was written on, there were 159 med students who went in to a conference, and they were assessed on whether they were able to measure blood pressure correctly following these steps. And unfortunately, only one out of the 159 were able to measure blood pressure. Sorry, this is incorrect the way I wrote it, but only one got it correct. And no wonder when you have, 11 things that they were being scored on, if you just make sure that the patient's kind of following this here, feet flat, arm up near their heart, they're resting, not talking. I often do the shh, go to your happy place when patients tend to talk. But this is part of the problem. And I think you have to remember that these data are fraught with error if they're not measured correctly. So therapeutic management principles, and I'll keep it short here. First, use evidence-based guidelines. I tend to use the 2017 AHA-ACC guidelines. Recognize that there are pitfalls in the blood pressure measurement provided for the patient that's in front of you. Don't treat the number, treat the patient, and feel free to always check again that blood pressure measurement. And always discuss lifestyle first, often, always. And I'll go ahead and end there, perhaps with last slide.
All right, we have a quick question. How often you use clonidine in your practice?
Oh, the dreaded clonidine. Well, when I'm 3 and 4 down the road with regards to antihypertensives, I will reach for the clonidine. It's in the armamentarium. It's not a first line for me, nor a second or third, but I will reach for clonidine. It's tough. It's a tough one to get folks off of, and I do think that before that, you should be working up secondary type of, refractory hypertension. You should be looking at what else might be driving this.
Absolutely. Definitely, it's not the first line or the second line medication. A lot of side effects. So next on, Dr. Mark Ibrahim is back on board, and see if we can start his talk on updates in cardiovascular imaging.
Perfect. Can everybody see my screen?
Yes.
All right, great. So it's pretty embarrassing. The imaging guy can't get the computer figured out here. I'm sorry, guys. So for those who don't know me, I'm Mark Ibrahim. I'm a cardiologist at the University of Utah, and I do advanced cardiac imaging, specifically cardiac CTA and cardiac MRI, and I have a passion for those two studies. So we'll briefly talk about updates in the field and specific, stress testing. One of my disclosures is research support from a Hartford company. This is the company that supports the FFRCT analysis. And my outlines here briefly talk about the non-invasive evaluation of coronary disease, then emerging role cardiac CTA and MRI in the evaluation left atrial appendage thrombus, MR angiography for aortopathy, and the advantages of cardiac imaging during pandemics. Just a quick concept that it might be a little technical, but I'll simplify it. It will help in terms of the choice for the test to answer the specific question. There's in radiology a concept called spatial resolution and temporal resolution and a contrast resolution. So spatial resolution in brief is basically the measure of the smallest object that can be resolved by a sensor. So if you want to image a very small object, you need to look for a study that had a high spatial resolution that can catch up with this. So basically, for example, here, the spatial resolution of a CT scan is a 0.5 millimeter and almost similar to echocardiography, that means those two modalities can image a very small structure up to 5 millimeter compared to SPECT imaging 4 to almost the average is 10 millimeters. So a centimeter structure to be able to show on a SPECT versus like on a CT scan. And the temporal resolution means like how fast the imaging modality can catch up with the moving object. So clearly, if you're doing valvular imaging, that you would go with the very high temporal resolution modality like an echocardiography, rather than like just going with the CT scan to move a moving object. So this is just a concept in terms of the choice of the imaging modality. Then the bread and butter practice for cardiologists is the evaluation of coronary artery disease. Basically, we have a menu of all these various testing, and Suhail mentioned before about like which test to choose and what am I looking for. And it's not a simple question to answer here, because multiple issues here are in play in terms of the regional experience, local experience, the patient-related factors, and also insurance-related factors. In general, to simplify it, as a primary practitioner, when you're considering a choice of non-invasive evaluation for coronary artery disease, I would ask those questions. Can your patient exercise? And then that will determine, like, is this a pharmacological versus treadmill stress testing? Is the ECG interpretable? And we will touch on what is an interpretable ECG. And what is the body habitus? Is the patient like morbidly obese? Am I really going to see the heart if I do an stress echocardiography? Then is there any baseline wall motion abnormality in the left ventricle? Has the patient had a prior multiple heart attacks? And that's going to really change or compromise the quality of the stress echocardiogram if you're doing that. So those questions in mind, and then look at the ECG, and it's the guidelines define the uninterpreted ECG as if you have a ventricular pace rhythm, left bundle branch block, resting baseline ECG, ST depression more than 1 millimeter, or patient is on digoxin with the significant ST2 wave abnormality, left ventricular hypertrophy, and Wolff-Parkinson White. Basically, what we mean under interpretive ECG is those ECGs, like this one here in the picture, has already baseline abnormalities that could compromise like ischemic changes evaluation, and will change the accuracy of the test. Exercise tolerance test, which is like the old-fashioned, it's been there forever. It's basically put your patient on a treadmill and see how they do. Monitor their ECG changes and symptoms, and if any exercise-induced arrhythmia, any exercise-induced hypertension, and it can be ordered, as long as the patient can really exercise. Sensitivity 65%, which in my opinion, not great, and you're gonna miss coronary disease, obstructive coronary disease in 35% of the cases, and also widely available and at low cost. If you add imaging component to this, you crank up the sensitivity specificity to about 72 to 85% respectively. And basically, this is, you add basically echocardiography to the treadmill, widely available, cost effective. But also, if you have multivessel disease, the sensitivity could be better in terms of the, Suhail, can the audience hear me?
Yes.
I can hear you.
Okay, for some reason I lost the side panel. All right, so exercise stress echocardiogram can provide also an additional structural and functional information of the heart and the valvular disease. Although baseline resting wall motion abnormalities may degrade the image quality because you already start with wall motion abnormality, then you start looking for, is this really gonna worsen with exercise or not? So it will be operator dependent if you have issues with multiple prior heart attacks. No radiation exposure, which we all understand and we appreciate that. Then we come into the pharmacological stress test here. Basically, this could be added to any other test, like you can add it to the stress echo, make it pharmacologic stress echo or a pharmacological nuclear. We use two different agents. I mean, we prefer to do it only if the patient cannot exercise or has a poor exercise tolerance and could not accomplish target heart rate. Basically, vasodilators that we use, Lexiscan here at the university, and it's widely used everywhere else. Selective A2A receptor agonists, and the concept here is not to increase the heart rate. It's basically to induce what we call a relative coronary steal or ischemia. So if you have a coronary artery with more than 50% luminal stenosis and you do vasodilatory effect with those agents, the artery with the stenosis will cause relative ischemia or relative steal compared to the others and will show as perfusion defect. There are contraindications for this in hypertension, sick-sinus syndrome, and advanced AV block more than grade 2, and severe bronchospasm. However, with the newer agent, Lexiscan is very selective, so it has to be really, really severe COPD or asthma. Then we have the other agent here, chronotropic, inotropic dobutamine, which is like agonist with beta-1, beta-2 receptors, increases heart rate and contractility, causes some side effect, including hypertension, flushing, and headaches. So this one, you should be cautious if the patient had LVOT obstruction, aortic dissection, and also moderate severe systemic hypertension, so more than 180 resting systolic blood pressure, then we actually don't do it. So we'll move on here to the widely adopted pharmacology. I mean, well, actually, it's like the spec that comes with pharmacologic or treadmill. This is just full disclosure. This is not my favorite, despite the fact that it's widely available and most cardiology practices has it. It is significantly operator dependent and most of the times produces a lot of artifact, breast attenuation artifact, diaphragmatic attenuation artifact. So, I mean, if it's done right, it's fairly good test. However, I mean, at least anecdotal experience, it's not the best test here locally for the patients. It could be as a sensitivity as up to 74%, specificity 79%, and the performance depends also on the prevalence of the disease and the population being tested. So you will see in my slides different sensitivity, specificity down the road, but it's all dependent on the population being studied at. So can be performed as treadmill nuclear or pharmacological nuclear. It will give you basically ischemia burden and also TID, transient ischemic dilatation, just goes with multivessel disease or so. Another nuclear test is basically the state-of-the-art, top-of-the-line nuclear imaging, which is the positive emission tomography, PET-CT. Depending on the radio tracer that is used, the sensitivity specificity is different, and it could be higher than 87, actually could be up to 90% depending on what radioisotope. You can get LV function myocardial perfusion reserve, which is an important thing if you're looking for microvascular dysfunction, and if patients continue to have chest pain and no epicardial coronary disease, and you can look for this myocardial perfusion reserve. It gives you ischemic burden, also calcium score, part of the scan. It has radiation exposure and not widely available, and also insurance coverage. I do not have a personal experience. We do not do it here, but our partners at Intermountain had a very high volume center here. The reason to consider this, if you're looking for, myocardial function, ischemia burden, perfusion reserve, and radiation is not an issue for this patient, I would say you can go then with the PET-CT. It's not, you can't do treadmill, it's a pharmacologic, and I believe they use Lexiscan there. We come back to the cross-sectional imaging here, cardiac CT angiography, which I do quite a few of those. It's a quick test, very low radiation time, radiation exposure, and covered by most insurance companies nowadays, have high spatial resolution, and it gives you anatomy, function, And with the addition of FRCT, which is non-invasive add-on, we'll elaborate on it in a minute, it gives you physiology. So you get anatomy and physiology, and you get plaque characterization, which is very important for prediction of future cardiovascular events. And disadvantage, you give ionized radiation, and you have a risk here for contrast-induced nephropathy. However, it's a low-dose contrast and requires some cooperation from the patients. So basically, holding breath for 5-10 seconds and following commands. One of the landmark studies supports the use of coronary CTA is the SCOT-HEART trial, which is a randomized multi-center trial looked into the use of coronary CTA for patients with suspected stable coronary disease versus standard of care only. So standard of care only defined as like anything you do to your patients in the office, including medical therapy plus any of the traditional non-invasive testing, any stress modality, except coronary CTA. And they randomized those patients to the two arms of the study, and about 4,100 patients, and they look into death from coronary heart disease or non-fatal MI over like 5-year time frame. And surprising, well, not to me, I mean, I believe in it. So, but interestingly, the curve separation here was very clear early in the game. And at 5 years, it showed that if you pursue a strategy of coronary CTA to your patient, they suffer from less cumulative cardiovascular event compared to patients with just like the traditional non-invasive testing. And the conclusion of the study was like the use of coronary CTA in addition to standard care in patients with stable chest pain resulted in a significantly lower rate of death from coronary disease in non-fatal MI at 5 years, without resulting in a higher rate of coronary angiography and revascularization. So again, this like made the coronary CTA as an alternative standard of care, including conventional stress testing and evaluation patient chest pain. So basically, you have a patient with a 20% LAD stenosis, you don't know about it, you put the patient on a treadmill, this patient may pass the treadmill stress echo with flying colors, and you'll tell the patient, oh, keep doing what you're doing, you're in good shape. The same patient, if he goes for coronary CTA, you'll be able to see the plaque and characterize it and start aspirin and statins early in the game and basically change their course. And this is where the power of coronary CTA. Another cross-sectional modality that I do quite a lot of this is the cardiac MRI, which we all know it's non-ionizing radiation, high spatial, high temporal resolution, and you can do tissue characterization. You can look at the function, morphology, and all, and you can even get microvascular dysfunction evaluation. However, it's requires a longer scan time. The shortest you can do it like 30 minutes, but it's usually an hour and a half. Questionable with the insurance also coverage. You may have to justify or do peer-to-peer study reviews to get it approved. And there is a risk for the contrast-induced nephrogenic systemic sclerosis with the gadolinium. However, the newer gadolinium agents that we use are FDA approved, which was approved about 6 months ago. Contraindicated if patient had a pacemaker, aneurysm clip, and other intracardiac devices. There is a tremendous amount of evidence and trials supporting the use of stress myocardial perfusion and has a very high sensitivity specificity compared to other modalities. And I will skip this for the audience who never look into it. It's basically a real-time acquisition. We give vasodilator, regadinazone as well, and inject gadolinium contrast and look for any perfusion defect. Resting imaging here and stress imaging here, and any perfusion defect can be quantified in terms of the size and the severity. And this is just like a patient with HC. Actually, it has like some microvascular dysfunction. You can see diffuse here, low signal intensity with stress. Another patient here, just like with the stress MRI, and you can see perfusion defect here compared with resting images. How do those modalities perform? This is based on a Circ imaging meta-analysis of actually 37 studies included in this analysis, and it shows the various sensitivity, specificity of different imaging modality. This is where SPECT performance here compared to stress echo, where we said about 69% sensitivity and then 84 specificity. MRI is higher. PET-CT is also high. Now, depending on the radiotracer use, it could be higher, up to 90% again. And coronary CTA is as good and probably better than PET CT in this trial. However, here this is based on the 2015. Basically, the scanners have progressed, and the contemporary scanners will produce better quality. So I hope this could, help you at least guiding your decision, knowing what's the sensitivity for that specific modality to detect obstructive coronary artery disease. This is a single, it's a study in Europe, questionable and controversial on a lot of issues, but the concept here, I don't know how they got their institutional IRB, or if there's any to approve it. So basically, it's about 250 patients. All of them underwent coronary CTA, SPECT, PET, and invasive FFR. And they compared the sensitivity, specificity, predictive values here of all of them. And again, they kind of concluded that coronary CTA has a 90% sensitivity compared to SPECT 57 in their institution, and the PET was 87. Again, this supports the superiority of coronary CTA and PET among the other imaging modality. In terms of a radiation dose, I'm sure your patients will ask you, how much radiation am I getting with this test? So if you look at the natural background radiation in just living in the United States, over a year, you get 3 millisievert. That's the unit that we use in radiology. So if you base your exposure on this, if you get a chest CT, just a regular chest CT, it's actually a high radiation dose. If you do a chest X-ray, it's a 0.1 millisievert, but what I want to point here is a coronary CT angiography with the contemporary scanners is between 3 to 5. So you're just exposing your patient to 1.5 the yearly natural exposure, compared to if you do nuclear SPECT here, you're giving them 10 millisievert, which is about 2.5, well, 3 times actually the yearly radiation exposure. Now, PET images, I would say in the 5, depending on the radioisotope, but please, please, please don't ever order the thallium nuclear stress test, because it's about 22 millisievert, really high radiation dose for no justifiable reason. Where does coronary CTA stand in the current guidelines? We're still, these guidelines are still 2012. A lot of advances are underwent since then, and now they're rewriting the guidelines, and they're gonna follow probably the United Kingdom guidelines. They're in terms of putting CTA as a first choice for chest pain. So if you have someone low to intermediate pretest probability for heart disease, and they're not able to do physical exertion, it's actually class 2A to do coronary CTA. And also here, class 2B, if you have somebody with CABG, and you don't want to do invasive angiogram and you want to look directly at the graphs, or if they have stents more than 3 millimeter lunar stenosis, class 2B in the guidelines. It's also appropriate to do coronary CTA if you have a prior stress imaging with equivocal result, like discordant ECG and imaging changes on the stress echocardiogram. You can do this. For those in the audience who never got ordered coronary CTA, the reporting kind of here is different than the invasive coronary angiogram. It's basically in quartile. This is how we report it. And if anything more than 50%, we start looking for FFR CT, which is basically physiologic assessment. And this is how normal coronary arteries look like on the CT, LAT. This is here basically 2549 luminal stenosis. Again here, LAD lesion, this is called 70 to 99%. Left main disease, and the beauty of the coronary CTA is, this is how you look at the stent here with the in-stent stenosis. Beauty of coronary CTA is you can look at the plaque characteristic and define high-risk features, or what we call a vulnerable plaque. This is the plaque that could rupture in the near term and then cause ACS, and you can escalate therapy based on this. And there are specific CT features. Warranty, that's what I call it for the patients. If you get a normal, clean, normal, no calcium, nothing, no soft plaque on a CTA, with a study here done at 2,000 patient follow-up for 10 years, and they say the risk of having cardiac event over 10 years is very low if you have a normal coronary CTA for stable chest pain. Fractional flow reserve, the interventionalists here in the group knows this, and this is the gold standard, and they use it a lot. Basically, put a pressure wire in the cornea and measure the pressure distal to the stenosis and proximal to the stenosis, and any drop more than 20% distal is considered hemodynamically significant, and basically then that lesion is ischemia producing lesion. And there is a way to produce this in a non-invasive fashion, and we do quite a few of those at the university, and with the accuracy of this 86% compared to invasive FFR. And this is how we get it. You get a 3D analysis. This is just from the CT scan images, computational fluid dynamics, and then you get the FFR value distal to the lesion of interest. Coronary calcium scan, we all know if you have more coronary calcium scan, the other than 0, your risk of cardiovascular events is higher, and then management with statin therapy and other aspirin is necessary. One of the newer updates here I want to just talk briefly is, can CT and MRI look into left atrial appendage thrombus? Multiple meta-analysis using different data showed that the accuracy of cardiac CTA is almost 100% compared to transesophageal echocardiogram. Several studies called also MRI looking for left atrial appendage thrombus is in the 90s compared to TEEs. And basically, we started doing quite a few of those, and this is cardiac MRI looking left atrial appendage. And again, here you can see with cine images how it's hard to miss this. This is an MRI. Also with cardiac CT angiography, we can look into left atrial appendage sludge versus left atrial appendage thrombus. And this is how the left atrial appendage look on cardiac CTE, full cardiac cycle, retrospective gated, we call it. And evaluation of aortopathy. One thing I want to tell the audience, in case you have patient with the aortic aneurysm and you're looking for serial surveillance of the aorta, I would try to avoid ordering CT chest. We have developed like dynamic contrast-induced MRA that gives you as accurate as a CTA and no radiation, especially for patients who undergo like serial multiple testing. And I have done a couple of cases here actually is non-contrast, just using the patient's blood in terms of looking at the aortic valve annulus with patients with advanced kidney disease. This is actually used for TAVR, and our interventionalists use our MRA non-contrast measurement to do TAVR, and it ended up with excellent result. This is again example of just using the patient blood as a contrast and looking into the aorta. So you can do this for patient with chronic kidney disease. Final slides here, just looking into use of advanced cardiac imaging in the pandemic. As we know, the COVID situation, was very unprecedented time, and we started stopping all cardiac, most of our TEE testing was canceled, and we were encountering a problem with those patients AFib with RVR, and they cannot undergo TEE cardioversion. We became really creative and started using left atrial appendage imaging through cardiac CT and MRI, and developed a specific workflow, and we call it now CT-CMR cardioversion. And we were ordering this with actually a high success rate. We did about more than 30, and it's been very successful. And we were able to continue patient care with those symptomatic AFib patients. And moreover, we expanded our workforce here capacity and consuming less PPEs and deploying our nursing staff to different areas where they need to use COVID. In summary, cardiac imaging is undergoing rapid evolution with high quality evidence available to support the clinical practice. There is FFR CT analysis that provide functional information complementary to the anatomic information you get from a cardiac CTA, which will help decision making in terms of cardiac stenosis. Cardiac MRI CT can be a reliable alternative to TE in detecting left atrial appendage thrombus, and the non-contrast MRI can be an alternative way for patients with chronic kidney disease and have aortic aneurysm. And thank you very much.
Thank you, Dr. Ibrahim. That was very detailed, comprehensive talk, and you tried to put everything in 20 minutes. So that was a great job you've done. So does the audience have any questions here?
I have a quick question. Thank you, Dr. Ibrahim. That was a wonderful talk. as in a practical sense, often trying to get authorization for cardiac CTA versus cardiac MRI leads us to basically nothing. How about using a SPECT along with the calcium scoring that we have utilized in our practice recently? What is your thought about that as opposed to cardiac CTA?
Oh, absolutely. I think the SPECT with calcium imaging is definitely better than just SPECTs alone, because at least you have coronary atherosclerosis on the calcium. The issue is still with the SPECT, you could miss those non-obstructive coronary disease, like 20%. You need at least 50% luminous stenosis for the vasodilatory agent if you're using a pharmacologic SPECT to produce ischemia on the SPECT. And also you're encountering here with the breast attenuation and the body habitus, unless the SPECT is done in a center where they do the prone imaging routinely or attenuation correction. Although I still found a lot of artifacts with the attenuation correction and compromising the accuracy. I think it's a reasonable alternative, but in my opinion, you're still missing those non-obstructive plaques, and you will get reassured if the patient had a non-calcified soft plaque. It's not going to show on the calcium after SPECT as well.
Well, thanks for that question. Dr. Bahadur is joining us from Phoenix, Arizona. So let's move on to our final talk of the day, and it is a very controversial talk. That's why I put this talk all the way at the end, so that our audience can stick around. As you know, earlier this year, there were, or late last year, there were news, like a breaking news, that the new research has come that the cardiac stent, they don't work, or we are overusing cardiac stent. And it was basically based on the ischemia trial. But Dr. Bawa Reddy, he is an interventional cardiologist in Utah for the last 10 years or more, highly skilled, and he is currently practicing in Salt Lake City. Dr. Reddy, please go ahead and give your talk.
Okay, thank you so much, Dr. Khan. Let me share my screen first. Are you able to see my screen? Are you able to see my screen now?
Yes, okay, we can see it.
Okay, good. So I think I would like to thank all the faculty who actually presented excellent topics so far, and then also to the audience who are really patient enough to, spend more than 2 hours middle of the week to really enjoy or maybe gain some knowledge. So I just, without any delay, I'm going to go ahead and start, but I don't have any disclosures. But I have a complaint for Dr. Khan. He liked to give me a controversial topic within a week of notice, and then ask me to make you guys, enjoy this. Okay, so here I'm going to go ahead with this. So if you look at this particular, the article that came in New York Times in November 2019, and then it clearly says surgery for blocked arteries is often unwarranted. Research finds. Okay. First of all, why this kind of a study is being done? I think what was the kind of a scenario or the preemptive studies that led to this kind of a question for people to really do a study. So looking at what I'm going to do is I'm going to go over some of the past studies, and then what are the shortcomings with those, the previous studies. I'm going to talk about the study design for the ischemia study, as well as I'm going to go over with the study outcomes, and then also in the end, I would like to present some of the controversies that I really think probably, I'm pretty sure you're going to have the same questions too. And then despite all the things, what is the impact of this particular study? That's also is going to be important for us. So looking at over the past few decades, there's a major progress has been made in regards to understanding the pathophysiology of atherosclerosis, and then especially in the coronary artery disease. And then previous speakers definitely alluded to the fact that there is a maximization of optimal medical therapy, and then this is being widely used. I know, looking at this particular thing, so a question has been raised, is the revascularization in addition to optimal medical therapy has any benefit? If you're looking at that, there are some studies done in the past, and then there's a meta-analysis, and then I'm going to go a little bit about that. So in particular, when you look at the meta-analysis of 5 studies, they actually show some comparable outcomes between optimal medical therapy and the PCI. Especially if you look at like a Barry 2 and Courage trials, they have contributed most. I can say like a late, I think 2000, like maybe 9 or like a 10, this Courage trial made a lot of noise. I think it created a lot of controversy. We're going to talk about that also later a little bit. So looking at this meta-analysis that was published in 2014, if you look at the primary endpoint, they looked at death, non-fatal MI, unplanned revascularization or angina. In any of these studies, there is no statistically significant difference between the invasive versus medical therapy. But if you're looking at unplanned revascularization, if you look at the Courage study, Barry 2, and as well as like a FAME 2 study, there's a decreased instance of unplanned revascularization. And then also in FAME study, there is actually decreased instance of the angina. Again, there is actually a single center observational study with more than 10,000 patients that was published in 2003 in Circulation. What exactly this study says is that decreased cardiac death with revascularization in patients with more than 10% ischemia on the perfusion imaging. And this is the crossing point, and then all of us started to believe during our fellowship, and then we really respected this thought, and then we thought this is the gold standard, right? So here comes like other studies and then kind of talking about, no, I think there is not much of the benefit. But you're looking at combined all these studies, what are the like shortcomings of this particular trials, or like even talk about what is the like limitations of this. If you're looking at, there is a definite selection bias. Patients are all randomized after the coronary angiogram. And then also if you're looking at, there is no minimum threshold for ischemia and a stress test before they enroll the patient. A lot of the studies actually did not make start like regulating stents. And then also looking at a lot of the studies are not then used on the FFR guided PCI. Some of the studies not even like included doing this cabbage in this. So now coming to the future considerations for this study, the ischemia study especially, are like studies that really needed to be done. So will the higher risk patients, especially with the moderate to severe ischemia and a stress test, are they going to benefit with revascularization? And then if you are looking at like eliminating the referral bias, that's exactly like you randomize the patient before even you go into cardiac catheterization. And then if you're looking at use of the newer drug-eluting stents, are they going to make any difference? Again, use of the FFR guided therapy, will it make any difference? So I think this led to a final question of like, okay, is there any benefit again with the coronary angiogram or revascularization in addition to the optimal medical therapy? I think this led to the ischemia study design. So this study was funded by National Heart, Lung and Blood Institute. And then if you look at, there is a funding also from the industry, but they never had any access to the study design or like collecting the data or like publishing any of the articles. This study was done in like 320 centers in 37 countries across the world. And then if you're looking at the study design, basically patients with a moderate to severe ischemia is the criteria here. And then I'll explain like what all these things are. And then they blinded actually with the coronary CTA. And then if the core lab says they are eligible, patients are randomized into two groups. One is the optimal medical therapy, but plus like a cap. And then the other thing is the non-invasive only optimal medical therapy. What are the endpoints they're trying to look at? There are like two types of endpoints they're trying to look at. One is the primary endpoint, and then second category is the major secondary endpoints. Again, this is the time to CV death, myocardial infarction, and then hospitalization for unstable angina, heart failure, resuscitated like cardiac arrest. Coming to the major secondary endpoints, again, the CV death, MI, and the quality of life. If you're looking at this study, it has got almost like 5,200 patients in this study, and the mean duration of the follow-up is 3.3 years. Actually, this led to a good power and precision for the study. And then eligibility criteria. If you're looking at the eligibility criteria, so the age has to be more than 21. And then looking at the moderate ischemia, they included all different categories so far. The previous speakers talked about, it's a nuclear, as well as the echo, CMR, and then exercise stress test. They also included coronary CTA. So coronary CTA more than 50% when somebody has imaging positive study. If somebody has an exercise stress test positive, they have to have 70% stenosis. And then the exclusion criteria, I think this is going to be something important for us. Patients with a New York Heart Association class 3 or 4 heart failure, unacceptable angina, despite being on a good medical therapy, and then ejection fraction less than 35%. Looking at the acute coronary syndrome within like 2 months, if somebody had prior PCA or CABG within like a year, and GFR less than 30 or on dialysis. If somebody has unprotected left main, the more than 50% stenosis, they also were excluded from the study. If you're looking at this enrollment, they screened approximately 8,500 patients. There is a screen failure of approximately 3,300. And then if you're looking at approximately 5,200 patients were randomized equally to the both groups. The important thing here is median follow-up is 3.3 years in both the groups. They have a good follow-up of all the patients, more than 99% in both the groups. If you're looking at the baseline characteristics, they're pretty routine, and then they are very, very well matched in both the groups. Now coming to the ischemia. So more than 50% of the patients have severe ischemia, and then a third of them have at least moderate ischemia. And then if you are looking at the baseline coronary anatomy by coronary CTA, and then two vessel disease is noted in a quarter of a patient, and then half of the patients have triple vessel disease. So overall, multi-vessel disease is noted in 75% of the patients. And then if you're looking at LAD involvement, is almost close to 90% of the patients with the LAD involvement. If you're looking at the risk factor management, these patients were reasonably well managed before even entering into the study. Baseline LDL is 83. And then end of the last visit is 65. That means they were really treated well in terms of like maximizing their medical. So the medications, other than like what we're talking about, they use is beta blockers, calcium channel blockers were equally used in both the groups. Anti-anginal therapy is a little bit more in conservative therapy. If you're looking at the dual antiplatelet therapy, again, in the invasive therapy is a mandatory, so higher use was there. Looking at, this is an important slide to look at. Cardiac catheterization was done in 96% of the patients in the invasive category. And then if you're looking at revascularization is done only about 80% of the patients in this category. We are looking at conservative therapy group, 28% of the patients still they received the cardiac catheterization, and then approximately 23% of the patients received stents. If you're looking at the type of the revascularization, they have 3/4 PCI and then 1/4 CABG. So this is the important slide to look at it. Blue represents the conservative therapy and the red represents the invasive therapy. If you're looking at combined primary endpoints that you're looking at, there's no statistically significant difference between the two groups. If you're looking at the first 6 months, there is an increased instance of primary endpoints in the invasive category. If you go back and like look at the end of 4 years or close to the end of the study, there is a 2.2% decrease in primary endpoints in invasive group. Again, in the secondary endpoints, same story. There is a 1.9% increase in the invasive group, and then there's a 2.2% decrease in the invasive. And then if you're looking at any net benefit, there is no net benefit in terms of like a CV death, MI, unstable angina, heart failure, or like any other things that you looked at. Looking at the cardiovascular death, again, there is no statistically significant difference between the medical group versus conservative group during the follow-up of 5 years. Again, all-cause mortality, there is no significant difference between the two. If you're looking at myocardial infarction, again, there was a little bit high instance of the myocardial infarction in the first 6 months. This is mostly related to the procedures. And then there is a significant decrease towards the end of the study in the invasive group. The hospitalization for the unstable angina is a little bit higher in conservative therapy. And then if you're looking at hospitalization for the heart failure, it is a little bit higher in the invasive group. Again, when you're talking about any pre-specified important subgroups you're talking about, there was no heterogeneity of treatment effect. If you're looking at any category, if you look at like a ischemia burden, if you're looking at like a baseline ischemia, or if you're looking at like a multi-vessel versus single vessel disease, or if you're looking at LAD involvement, or like optimal medical therapy or not, it looks like in any category they looked at, there is no statistically significant difference between the two groups. But looking at the Seattle Angina Questionnaire score, this is a very important thing. The higher the score, better it is. If you're looking at the red line represents the invasive group, blue line represents the conservative treatment group. So basically, when it comes to angina and the quality of life, invasive group has done much better compared to the conservative group. Again, if you're talking about the frequency of angina, it is much lower in the invasive group. Again, quality of life is much better in the invasive group. If you're looking at this, including all patients in the study, if somebody has angina or like no angina, and then you're combining all the patients, I'm going to talk about what this real study problem is in the end. Most of these patients, they actually benefited with the invasive therapy in terms of like a quality of life and angina. If somebody has a daily or weekly angina, the benefit is much, much more. Even you're looking at the 3 months, 12 months, or like a 36 months. Again, if somebody has at least a monthly angina, again, they have seen like a lot of benefit with the treatment. If somebody has no angina, there's no benefit treating with stents. Now you're coming to this particular slide here, looking at if somebody has baseline angina, the frequency, if somebody has a daily versus weekly versus monthly, so what is the probability that they're going to live without angina after the intervention? If you're looking at weekly angina, there is a 30% absolute risk reduction in their angina frequency, and number needed to treat is only 3. And then if somebody has a no angina, there's no benefit in treating with the stents. Again, this same effect panned out over the next 12 months or 36 months of the study. Again, coming to the study limitations here, this is a non-blinded study. There is no sham procedure, and patients know that they received intervention. And then the patients who are in the medical study, they know that like they didn't get any intervention. Again, when you're talking about this study cannot be generalizable to acute coronary syndromes for the patients within 2 months and highly symptomatic patients, or if somebody has a left main or somebody has EF less than 35%. So they're also looking at low frequency of complications in this study. They said like this study is not generalizable to the centers where they have high procedural complications. Again, when you're talking about completeness of the revascularization was not addressed, as only 80% of the patients in this study were revascularized in the interventional group. When you're looking at the women, there's a lot of screen failures for the women, mainly because of less ischemia and like a more non-obstructive disease. Only 23% of the women were enrolled in this study. Coming to this summary of this particular trial, the curves for the primary endpoint as well as the major secondary endpoint cross approximately at 2 years. There is a 2% higher estimated event rate in the interventional group at 6 months, but there is a 2% decrease in estimated event rate in the invasive group at 4 years. And then we are looking at hospitalization for the unstable angina is higher for the conservative group. Hospitalization for the heart failure is higher for the treatment group or the invasive group. At 6 months, again, there is a small increase in procedural MI, but beyond the 6 months, there is a significant decrease in spontaneous MI in the invasive strategy group. And then all-cause mortality is pretty low in both the groups. And then there is no heterogeneity of the treatment effect. A very low procedure related like a stroke or death in this group. So when coming to the conclusions here, so ischemia definitely is the largest study which compared invasive versus conservative therapy for patients with a symptomatic ischemic heart disease. So you need to use the word like a symptomatic here. So when it comes to initial invasive strategy versus initial conservative strategy, this study did not demonstrate reduced risk for a period of a median of 3.3 years of follow for primary as well as the secondary endpoints. And then when you're looking at the quality of the life, the patients with the angina, especially when you're talking about daily, weekly, or monthly, there is a significant as well as the durable impact or improvement in the angina control, the quality of the life improvement, quality of the life markers. When you're looking at this 3 months, as alluded earlier, there's a 30% absolute risk reduction, and then number needed to treat is 3. That means it's a pretty, substantiating in terms of like whether to treat a patient with angina or not. And then when it comes to the rest of the 12 months or 36 months, patients who underwent the intervention for various reasons, they really notice significant improvement in their angina control. Patients without the angina, invasive strategy has no statistically significant benefit. Okay, so I think I like to, probably summarize or like my understanding about the controversies with this trial, and then we can have some discussion after this. Looking at this particular trial here, the PCI group has 20% patients, they were not revascularized. I think the reasons mentioned is basically non-suitability of like coronary anatomy, that they are like not suitable for PCI, as well as the CABG. And the second thing is like a patient preference is one of the reasons why they mentioned that they couldn't get this particular group of patients not revascularized. And then looking at the optimal medical therapy group, you look at the 23% of the patients received PCI at end of the 4 years. This is a significant number of crossover. If you're looking at the COURAGE trial, there is 14.5% crossover was noted. And in this study, there is a 23%. If you're looking at left main disease, this was not included in the study. So there's another shortcoming definitely. And then looking at 49% of the patients had a no angina 1 month prior to the enrollment. I think this may be a reason for no difference between the study results. And then if you're looking at, again, there's only 23% of the patients, so 23% of the patient population is women. And then again, you cannot generalize this study to the women. And then you can talk about what is the impact of this ischemia trial, right? So we know that COURAGE trial was not done properly, or like maybe there are a lot of shortcomings. But despite that, we have noticed significant decrease in number of stable PCI and then unstable angina. And then when you're looking at the ischemia trial, I think I'm going to think probably it's going to decrease number of PCIs also, especially in like obstructive CAD with stable angina. Thank you very much.
Thank you, Dr. Reddy. That was a great talk. Does anyone has any question in the audience? Dr. Brinton, do you have any question about this trial?
I do. Very, very interesting. And unfortunately, both the invasive and the non-invasive treatments are moving targets. Now, we're always developing new techniques and new methods. The on-treatment LDL was good, but it would be interesting, wouldn't it, to take that same group with, what was it, the LDL was 68 or something on treatment, and maybe put them on a PCSK9 inhibitor, drop them down to 20. That would be kind of interesting, wouldn't it? What about taking the folks with diabetes, or maybe not even with diabetes, maybe with, stage 1 congestive heart failure, or who knows what, some renal disorder or something, randomize them to SGLT2 inhibitors? What about the folks with a triglyceride over 135, randomize them to icosapent ethyl? I mean, it gets really hard very quickly. But I love what you're showing about the angina. That's very convincing. And I think those of us that don't do the invasive stuff, we need to remember this, that when angina is any kind of an issue for the patient, we shouldn't just say, oh, there's no benefit for revascularization. But that said, I think going back and looking at the more aggressive medical therapy might be interesting, might be illuminating. I don't know. I mean, very, very difficult to do all these studies, but I think to think about them and then maybe see what might be studied. But I love your presentation. Fascinating stuff, things that the non-cardiologist needs to know.
Yeah, so I definitely agree what your comments are, Dr. Elliott. I think I totally agree that there should be a big role for the medical management, no doubt about that. Because I was going to ask you an earlier question too, because I was reading about, or like even we know 2 studies published early 2000s, prove it and reversal trials from like a Harvard as well as from like a Cleveland clinic. We know that like aggressive medical therapy, there is a decrease in clot burden. And recently I was even like looking at some of the studies, especially with the vegan diet. There was a study published from India saying that there is a significant reversal of atherosclerosis burden. And then I was just kind of like looking through, I want to really get your opinion about looking at maximizing medical therapy in terms of decreasing the disease burden. And then also like other speaker, like I think it's Dr. Mark Ibrahim talking about vulnerable plaque. I think we all know about that vulnerable plaque can be a big issue too, no doubt about that. I think the optimal medical therapy definitely has a role, but we cannot ignore the ischemia, as you said earlier.
All right, guys. So anyone in the audience, I know we went a little over time. We really apologize, but the talks were very interesting. And if any of the audience has any question, they can turn on their camera, can ask question. We'll wait for 2-3 more minutes. And we are recording this session, so we will be sharing that upon request. You can email me, we'd love to share. Dr. Bahadur, do you have a question?
I just wanted to make one comment. You know, looking at this ischemia trial, the way I look at it, it tells us and encourages us to use the medical therapy, lifestyle modification. But the one peace of mind it gives us that if these patients do not undergo any intervention now, they are stable enough that when they do need intervention, we have time to go and take care of these patients. They will not die at home. They will not have an MI. So I look at ischemia trial as giving me enough confidence to start the medical therapy before I proceed with any stentings and intervention.
And the one thing that we should remember that the ischemia trial does not address acute coronary syndrome, which is an entirely different animal. If someone comes in with non-ST elevation or unstable angina, those patients, there's definitely mortality benefit of doing PCI. Ischemia trial is for those chronic, stable ischemic heart disease. So that's one difference we should always remember. Any other questions from the audience?
Yeah, so I think like just to add one thing, as Dr. Khan is talking about, like if you look at this particular slide, I just wanted to include to see people with significant obstructive disease. What they're going to have is a less lipid core, and then the calcification, fibrosis, the chance of the plaque rupture and somebody dying is low. Rather, they will have more of ischemia. But as Dr. Khan talking about the vulnerable plaque, which you cannot detect on routine stress tests and symptoms, they have actually a thin cap and then like a lipid core, which actually can has a rupture, and then that can lead to sudden cardiac death or like, you know, all the stuff that we are talking about. Definitely, I think the optimal medical therapy has a role, but this is not going to really address the question of are we overusing the stents.
Sure. And then if you have a patient who comes to you with new onset chest pain, which is the definition of unstable angina, or if they have previous angina, now it's more frequent, more intense, lasting longer, that's acute coronary syndrome. So those patients needs to go to the hospital. So that's pretty much it, guys. On behalf of our audience, we thank our faculty, for taking time out of their very, very busy schedule. Again, it's all volunteer-based. It's all free. There's no payments or nothing. It's just out of love for education that all of us got together, and we hope to continue to do that every 2-3 months. And please stay in touch and email us if any question. Follow us on our Twitter. If again any question, you can always message us. And thank you so much, and have a good night, good evening, and stay happy and healthy.
Thank you, Dr. Khan, and then thank you all the faculty and then listeners. You guys have a great evening.
And Viet Lee, thank you. We could not do it without you.
Thank you all. Appreciate it.
Thank you. Okay, guys. Bye-bye.
Okay, bye everyone.